I'll deal with this edentulous case. Right. You know, you have Dr. John will have some input here because he was also reviewing what we did. So because it's an edentulous case, we now have to use some kind of analog method for the pre-processing, but thereafter we went ahead to use the digital technology. So let's move on. So in terms of the technologies that we use in the lab for the project, of course, this is what we now use. Once we had we now had the cast, the master cast, for the upper and lower. After dealing with analog method up to that point, of course, we now use, of course, our ENOS scanner for scanning. Then, of course, this is for design. Then, of course, like I said, we did the milling, but we are going ahead. Of course, we use the 3D print. This is a sprint tray for the trial. But eventually, because the project is not completed, we are going to now use, of course, carbon. We'll send our STL file to carbon to 3D print. But what is key and what I've already mentioned is that normally here in Canada, we use IPN teeth. We do not 3D print the teeth. It's not allowed yet as at now. So that is the limitation, not on our side, but that's how the system is. Right. So this is just a very basic methodology for denture base. You scan, you design, manufacture, and then you bond. So this is the suite of what we have in our lab. So what we have in our lab, of course, a scanner, as you have just seen, scanner, of course, this is our design suite, and of course, this is our milling, and that's our 3D printing. So we have the complete range of whatever we need right across from scanning, design to manufacturing. Right. So that, of course, like I said, we're trying to establish the bite, and of course, we had to get this done, and using analog method. Right. So I'll be very interested, Chris will be very interested to see how this can be done digitally. I'll be discussing with Dr. John because he was, giving us some kind of, feedback. I want to see how this can be done without going through analog, so that we can have a full-fledged, digital workflow. Right. So here we are just trying to establish the bite registration, and thereafter we'll move on to select, the system based on how we set the parameters, the system now will present us with some initial solution, which we now have to work with, depending on what we are looking at. And of course, we can now, based on the design, we can have a monolithic try-in before we go to the final denture. Right, so either you mill or you 3D print. So this is a picture of our try-ins that we got before we did our actual final design for the denture that was fitted. Okay, so once you have done your design, I've already said that for the base, and you've done your milling, of course, milling or 3D printing, you have to now choose your IPN teeth. So this is the methodology that we use here in Canada for now. Like I said, you do not 3D print the teeth, you just select off the shelf. And the simple reason is that right now, as far as I know, right now the state of research is that there is no. Dr. John may want to come in here. I do not know of any 3D printed teeth that compares with zirconia. That is still in the lab stage. Okay, I've read about that some work is being done, but I do not know whether it has been FDA approved. Because if it is not FDA approved and not Health Canada approved, we cannot use those teeth. So for now, this is what we are using. I do not go for this. The reason I do not go for this option, which is milling the PMM teeth, is that this takes a long time and it is not productive as far as I'm concerned. Right. Whatever happens, whether you got the IPN teeth off the shelf, you have to do some bonding, and the HIPAA, which is high impact acrylic, is normally used to bond the teeth to the base. And of course, this is now our denture that we now design for the patient. And of course, that's the patient, puts on the upper and lower. And of course, there were feedbacks that were positive, but we are still keen to pursue this a little bit further with Dr. John based on his feedback. So that was now the first part of first part of what we have done in terms of having some kind of value, because we're looking at the market here. I need to mention this. The goal of this project, the output of this project, is that we want to reach out to markets in developing economies, especially in Africa, right? So we are trying now to compare the denture base that we have produced, fabricated using milling. We want to compare that with carbon 3D printed. We know that carbon is going to be for sure is going to be much better than milling. And then of course we would also try and have the denture base, using the denture based material. We know that this is going to be inferior to carbon. But we know that. So carbon, we anticipate, is, of course, will be ahead of whether it is milling or. So carbon will be the way to go in terms of 3D printing. And of course, milling we have already done. I'm not interested in milling because in milling, it took us for the upper arch, it took us 3 hours for the upper arch was 3.5 hours. The lower arch was 3 hours, which is 6.5 hours. Whereas if we 3D print using a carbon 3D printer, it will take us, you have about 8 arches, at one go in about 1 hour. So 3D printing is the way forward as far as I'm concerned. We still want to retain the IPN teeth, digital denture teeth, because that's right now what is being used here in Canada. So we have the link. This is a link of that project that we just did, and I thought we should report this to show the power of digital technologies. That's the whole idea of I will imagine of this of this session. And then of course the second part of the presentation, and I will try to keep to time and manage my time. Dr. John, give me a shout if I'm lagging behind. The second part of the presentation is the second part of the presentation is how digital technologies enable collaborative work between two organizations located in geographically disparate regions. So here is I've already mentioned that. You can see that what we did was to take a small project, very, very small, very, very, rudimentary, between stars and crests. We discussed with Dr. John to say that we want to test something out. What do we want to test out? We want to test out whether we are here as your partners in Canada, you are there in India. Can we collaborate in such a way that we can, using a virtual platform, produce products that will be sold to customers either in India or in Canada, which are produced concurrently and jointly by stars and crests. Let me just ask every one of us, look at the distance between Chennai in India and Toronto here in Canada, because I checked the map, it's such a long, thousands of kilometers. How can we do business together if not for digitization? So this is a quote I just made up, that digitization has broken down the walls of localization of operations. It has significantly impacted on how business is done today. That's my quotation. So let's move on. We have several quotations. So look at the distance between Chennai and Toronto is 13,368 kilometers. I Googled it. I checked it. Look at it. We are here. I'm talking from here. Most of you are here in India, and we have Oscar in Europe. Can you imagine the power of technology? So he is somewhere here. We are here. Dr. Laura and myself here. Most of you are here. But right now the partnership is between stars in India, crests in Canada. How can this happen seamlessly if not for digitization? So I'm so excited in this. This is actually what drew me into this area some 4 years ago, and so we see that what we are saying is that in the age of internet technologies, digital data transmission is very, very fast, easy, seamless, and this is the key to realizing a poled design and manufacture network. So poled means we are bringing in stars in India, crests in Canada, putting our strengths, our resources together to produce, design, manufacture, and ship out products to clients, whether they're in India or they're in Canada or elsewhere. It's mind-blowing. To be frank, it is mind-blowing. So what I won't take our time here. So the key here is repeatedly you see the word STL, STL, S. So we are, as a company, we are using about 90% of our technologies are dense splice based. All right. So let me just move on. See this one page? This one page tells the story. You have scanning, you have the design, you have production. So if you scan, the next will be to design, next will be to to produce. But then you can see that STL, if you have your formats, the formats of your output of your scan, if it's in STL, if it's in STL, you can send your STL file to the design software, wherever it is, as long as it is STL, and once design is done, again, you can get the STL format and, of course, send it to the machine. So the key is that if you walk around the STL format for your products, nothing stops us. So let's just zoom in. Let's just listen to this. Nothing stops us. If we are here in Canada, our customers are here. We do the scanning and send the STL file to stars in Canada. STL file is to stars in Canada. They do the design. They can send the STL file back to us, and then we can machine, because our machines can talk seamlessly with STL. So if you stay on STL format, we can get customers in Canada, send the work to Dr. John in India, and he can return the STL file for us to manufacture and ship to our customers. So our customers may not even know that the design was done in India. They will think that we did it here in Canada, and vice versa. And so I want to move on very, very quickly. We have very quickly a case report of a patient here in Brampton, Greater Toronto, who wanted a restoration of 3-7 dentition. And a dentist here now had to send the case to us, and the dentist now wanted a full zirconia 3-7 shade A2 restoration. And so what we did very quickly, I want to move on very quickly. So what we did was to look for a local dental lab here in Canada, in GTA, we call it GTA, and also send, then from the cast model, we now send the STL file after scanning to Dr. John in India. We discussed with Dr. John so that there will be transparency. We're not trying to compare. We're not just trying to compare that local lab and Dr. John's stars, company in India. We're just trying to have some kind of comparison in terms of time, not quality, because we know exactly what we're looking for. So the company, the local company, took 2 days to deliver everything restored. And when we sent the STL file to Dr. John the following day, Dr. John returned it. So which proves that we can move forward. So what we did was I won't spend a lot of time here. So what we did was to do some kind of analysis here. So what we did was, when Dr. John sent the design back to us, we now milled it. And after milling it, we also 3D printed the model and fitted his the crown that he designed in India, but we milled here. We fitted it on the model, and we did the same for the crown that was designed here in Canada by another company. And this is now what we see, that the crowns. These are now the similarities between what Dr. John designed and that company. And then, of course, there were some, feedbacks in terms of Dr. John's, what Dr. John did and what the local company did here. And then, of course, we see that this is now the crown from the local lab. That's the crown there. It's a 3-7, right? This is the crown from Dr. John's lab. So we now, Dr. John gave us more information, because as far as stars is concerned, we only just send them STL file, which was not sufficient. So Dr. John gave us more information, and these are from Dr. John's feedback. He said, for any case that will be sent from Crest to stars, it will be useful if we send a detailed case history and request form. We should also send clinical photos of the patient's occlusion and teeth in alignment, and a scan of the patient's upper and lower dental structures with tooth preparation site well illuminated and demarcated, and we should also send a bite registration scan. So these are the feedback from Dr. John, which this, to me, this is mind-blowing, because we can hear the whole idea was not to say that this is better than that or this is better than that, but that we just send the scan, the STL file to STARS, and STARS came up with a product. We did this locally and so on. This the company locally had more information. Dr. STARS didn't have enough information, but Dr. John has guided us on what extra information that STARS will need so that we can now deliver products that will satisfy the customers. So with this very simple, straightforward, small experiment that I've just done, we have come up with some conclusion that we can, STARS, CREST, and STARS can collaborate. And what is key is for us to deliver high quality products that, at the right price, that is time sensitive. And so that now led us, well, I won't say led us, because we're just trying to validate a platform for this STARS CREST partnership. Okay, so we have proven that it is possible for us to work together, and the digital framework for intercontinental collaboration is what we see here. It's an adaptation from Dr. John's presentation. So here, nothing stops us from doing this. That you have STARS here, we have STARS CREST Canada, and that we can STARS CREST Canada that is here in Canada. We can get in touch with our client, get all the anatomical data, we can do the design here, and of course we can send the design to STARS team, and then they return the design solution to us, and we just simply 3D print and push to our client, and vice versa. STARS can do the same. STARS can send us anatomical model. We can do the design here in STARS and return. Yes.
Yeah, it's getting a little. Can you just wind up, Doctor? We have the others also.
I'm done. Yeah, so I'm done. So here we see that we have now validated the fact that we can have a platform for collaboration, and these are the advantages. And I do acknowledge my colleagues here in CREST, Dr. Leroy, Dr. Lufemi, Dr. John, for inviting us and for putting all this together, and for the organizers of the 3D GRAPHY Medical Expo conference. Also acknowledge our technician and all those that are listed here. Thank you very much. If you have a few questions, the contacts are there, the video link is there. If you have any question, I'll just take those briefly. Thank you so much for listening.
Thank you, Professor Godfrey. It was a wonderful presentation. I think talking about how STARS and how distance is not an issue at all. And thank you for taking us through the journey of digital dentistry and what can be done with Fresh. And I think with more and more applications and more people coming on board, and with more applications on, I think we should do an amazing job. Thank you for opening us the instant with the Canada perspective. We'll keep the questions to last, if at all is any. I'll now like to call upon our next speaker, Professor Dr. Abhay Kamath. Dr. Abhay Kamath is my mentor, and I've learned a lot over the years with him, working with him ever since I finished my maxillofacial surgery. And a person, when we started STARS, I think in 2014, when we started from 2015, Dr. Abhay Kamath has been a big support to us. That's a time when nobody was even there with technology, and people would not want to give it a try. But here is a person who said, John, that's the way forward. A visionary, in fact, and one of the very, very few surgeons. I mean, most of the surgeons that you have here and the doctors here are, in fact, market leaders in technology in their branches. So that's something that I want to watch, and that's for you to watch. And Dr. Abhay Kamath is a clinical professor and a chief of the Department of Oral Maxillofacial Surgery in KMC Hospital in Mangalore. He has finished his fellowship and observership under Dr. David Stutka in Toronto, Canada. So that's where the Canadian link comes in.
Yep.
And he went on to do his AO fellowship in trauma and orthodontic surgery under Adrian Sugars in Swansea, UK. He went on to get his TMJ replacement surgery fellowship again under the Biomed Academy at Atlanta, Jacksonville, Florida. And one of the very few people who did his observership under Dr. George Dimitriou, another amazing surgeon with technology-based work at Melbourne, Australia. So a person who's gone across the globe, learned the best, and is here with us to share the best with him. So I hand over the platform to Dr. Abhay Kamath to take us through what are his technology-assisted experiences. And over to you, sir.
John, you're able to listen to me?
I can listen, but you need to share your screen, sir. Yeah. Your voice is there. Can you share your screen? Yes, yes.
Can you see now?
Yes, I can see your screen, sir. Can you enlarge it?
Just guide me through. I'm a little bad in... Is this
correct.
okay?
No, so far so good.
Yeah.
Shibu, can you make it full screen, Shibu? Yeah, it's just perfect. So
okay.
Go ahead.
So my presentation is visible, right, John?
Yes, sir. Yes, you are visible and you are audible.
I'm audible. Okay. Good evening, good morning, gentlemen. At the outset, I would like to thank 3D GRAPHY for giving me an opportunity to share my knowledge with this august mixed podium of biomedical engineers, doctors, and researchers. My topic for the day is technology-assisted replacement options for maxilla, mandible, and dental components of the face. I'm sure we all remember this particular image from our yesteryears. Probably Rudyard Kipling, the most famous novelist from Mumbai, made this jungle boy a big part of our lives. That's Mowgli for you and his friends who kept us glued to our television every Sunday from the 1990s. But however, with the passage of time, Mowgli's adventures faded away. And it was then and today when Walt Disney brought him back in a big way with the use of 3D technology, which made us fall in love with this jungle boy once again. That's where 3D technology came in. When I speak about 3D technology, one needs to remember that 3D technology has shaped our present and now promises to give us a brighter future. It depends on us as biomedical engineers, doctors, and researchers as to how we would use this technology to shape our lives and as well as our patients' lives. Use of 3D technology in maxillofacial surgery. I'm sure most of the biomedical engineers would be familiar with this face. That's Dr. Charles Hull, the Chief Technology Officer from 3D Systems, the inventor of solid imaging process known as stereolithography or 3D printing. 3D not only revolutionized the motion pictures, the media and the engineering world, but also on the 15th of April 2019, scientists in Israel unveiled the world's first 3D printed heart with human tissue, or otherwise popularly referred to as bioengineering or biotissue engineering. If you see this particular slide from Gray's Anatomy, I'm sure you remember where students are given anatomical models to understand the complexity involved in each of the human organs, may it be the heart or the nose or the auricle. Every student has been given this to understand the intricacies involved in the human body. From here, we move on to some amount of literature as to how 3D reconstruction or 3D printing has shaped our present. The aspects of use in three-dimensional reconstruction, as Dr. Godfrey spoke about in his lecture, is not only restricted to prosthesis, but also with regards to simulation models, virtual planning, and also obtaining prototypes for us surgeons to practice even before the actual surgery. These are two journals which I picked up from where they speak extensively about 3D printing and 3D technology. Cutting Edge in Oral and Maxillofacial Surgery by Ayman Hegab, where he speaks extensively about the use of prototypes as well as the role of bioprinting. And the second journal, which I've picked up from Medicine Oral Pathology, where he speaks about virtual planning and 3D printing modeling for mandibular reconstruction with fibula free flap. The reason why I put up these particular journals is basically to understand the diversity of 3D printing technology in the field of maxillofacial surgery, extending on to involve even oncosurgery or cancers of the head and neck, where bones are taken from the leg and these are used to reconstruct the jaws. So 3D printing has a definitive role to play here with regards to lessening the operating time for the surgeon, being precise in placement of implants, as well as delivering utmost of care for the patients. When I go into 3D printing and 3D technology, I'm not going to waste much of time. I'm just presenting a few cases of our rendezvous with 3D technology. This is a patient who came to us with a depression in the forehead, where the patient had met with the road traffic accident. And it's at that particular time, the neurosurgeons called upon me and asked me whether I had a solution for this rather than the conventional bone flap. My colleagues here, Dr. Ganesh, Dr. John, and Arjun would understand in a larger diversity as to what I mean. So they were trying to understand whether they could get bone from the human body elsewhere. But I had an answer because I have been working extensively with John, and that's the time I called on CTARs to understand if they could help us. And that's the time John gave me an answer with the help of titanium as a material of choice. This is what John fabricated. As Dr. Godfrey spoke about, we sent him the CT scans of 0.625 raw data, DICOM images, and made him print these implants for the forehead. Initially, the implants were given to us on an STL model so that we could play around with the implant and see what was the perfect fit even before the surgery. We used the model what John provided, and that's the end result of the surgical practice. You see there the patient has got back his convexity where there was a definitive concavity in the second image. The first image clearly depicts how neatly the 3D printed titanium implant has taken its seat right in the center of the face and at the level of the frontal area or the upper forehead region. This is another patient who presented with a vague complaint. He came to me with saying that I have a depression on my face. On closer observation, we noticed that the patient was psychologically affected. This is where 3D printing can come into play. You have options in the market presently where you can take in implants of Medpore or Cyelastic, or those were the older ones which were being used. But today we have an answer to these kind of questions. Many in my field would say that this is an overkill. But for me, if you ask me at this particular stage whether this was an overkill, I would underplay it saying that it's not an overkill, but we responded to the patient's call where he was psychologically affected and we replaced like with like. When I say replaced like with like, if you see the CT scan images, you can see that there is a fracture there on the right side, which is depicted by my arrow in the red, by my circle in the red. The only option I had was to osteotomize or break it again and redo the procedure. As this was a long-standing case of more than 2 years, we would risk having a possible injury during the osteotomy for the floor of the orbit, where the eyes are there. That's the bone which supports the eyes on the undersurface. So I thought about John and again asked him, he was like a messiah for me, if you ask me. And that's the time John fabricated this and mirrored the left side to the right side and gave me a small implant there made of full titanium. Of course, nowadays what we do is, it's not only a one-way talk. I and John sit back to plan our cases based on what needs to be done. We have our web meetings to understand. That's where the biomedical engineers have an essential role to play. It's not that the surgeon has his discretion to say, I need this, I need that. What needs to be done is that there should be an understanding between the biomedical engineer and the surgeon. They need to be in the same frequency. They need to work on the same platform to give the best back to the patient. That's the implant which was placed there. Patient got back his facial appearances. You can see there the left side being mimicked onto the right side, and we have got back the malar prominence, what the patient desired. Okay, this was another lady where Godfrey spoke about use of full crown zirconias. This patient came to me with a partial edentullousness there, and she was referred to me by one of my close friends, and I was told to fabricate an implant in that particular area. This patient, being a student, didn't have the time because she had multiple teeth missing, and she had a road traffic accident from which she had lost out all her bone in the front of the upper maxillary portion. So what we did was, at this particular stage, we had only two options. Whether we would go ahead with conventional implants in the bone, do a grafting, and then go ahead with the surgical procedure, or we could go in for a single stage implant rehabilitation. That's the time I fell back on my mentor, Dr. George Dimitrolis, who runs a company called Osteoframe, likewise, like John. And he came and told me, why don't you go in for an osteoframe? And they were kind enough to fabricate an osteoframe which had extensions going on to the pyriform rim. It was a clip-on where implant-supported abutments were given, where it was a screw-retained abutment which was given for the patient. The requirement here is that the patient was on a very less of a time plane. So she wanted rehabilitation at the earliest. So the best answer we could have was go in for an osteoframe without the need for a block bone grafting from any other portion in the body, wait for a period of 6 months, and then go ahead with an implant placement. So we went ahead with this particular osteoframe. You see there, we've taken support from the titanium bars there and the abutments which were screw retained. We took up the patient for surgery, a single stage surgery. You see the implants there, the osteoframe being very well seated in that particular area. To increase or enhance the integration capacity, we placed what is called as platelet-rich fibrin over the area, and we temporized this particular patient on table. And when the patient came out of the theater, believe me, she was happy because she had the tooth in a day. And the image, what you see there, is tooth in a day. And she's still not come back to me for the permanent teeth at all. She's still in the intermediate portion of the dentures. I'm sure possibly Google World has recognized these people as some of the most beautiful faces in the world. And that's Taj Mahal, which you clearly can make out. It's an epitome of beauty. And the lower aspect is the painting by Vincent van Gogh, where there is, where there is some kind of asymmetry in the painting as well. So with this, I come to another section where I'm going to speak a little bit about facial asymmetry. When we speak about facial asymmetry, or patients who come to us with hypoplastic maxillas and hyperplastic mandibles, we need to give back to the patient a facial attractiveness, which depends upon the law of averageness, sexual dimorphism, and giving back the patient youthfulness. With this, I present a case where the patient came to us with a total deviation of the jaw towards the right side. And if you see the diagram, if you see the slide very closely, you can see that there is certain amount of increased growth in the mandible. And if you see the bird's view where the patient is seen looking upwards, there is a definitive overgrowth in the mandible or the lower jaw. And you see there is a slight shifting of the teeth or drifting away of the teeth on that towards that side. And this is the CT scan where you see that the entire mandibular plane has changed and it is tilted towards the left side. So what we did was we suspected that there was an overgrowth in the condyle, and we subjected her for a SPECT scanning, and we found that the condyle had an increased overgrowth rate beyond the growth of the patient. So what we termed it as condylar hyperplasia in our terms. That's the image for the condylar hyperplasia, and that's the increased uptake of the FDG. So I called upon John and asked him, can you do a 3D planning for me as to have a differential movement of the upper jaw going upwards to correct the cant of occlusion or the roll? When we speak about asymmetry, when we speak about patients who come to us with facial asymmetries or when they have lost their youthfulness, there are three terms which the biomedical engineers need to understand. That's the roll, yaw, and pitch. These are similar terms which are used in the aircraft industry, where roll means you're rolling on the bed, pitch is a possible superior-inferior movement or an up-down movement of the tip of the aircraft, and yaw is a sidewards movement. So in this particular patient, John fabricated the STL models there. He made us cutting guides as well to understand how much of the upper jaw would move in comparison to the lower jaw after the osteotomy. And this is an innovation which John took up from my side, as well as a fantastic guide for us to cut off the lower border of the lower jaw so that we could save the nerve which supplies sensations to the lower part of the lips. So this was the cutting guide. We went in and removed that portion of the condyle which I had overgrown. That's the portion of the condyle which had overgrown. We did a differential impaction at the left one level. When I say differential impaction, one side of the maxilla would go a little higher than the other side. We went in and fixed the upper jaw. And then we did an osteotomy of the mandible on the lower side, on the unaffected side, so that the mandible could be moved. And then came in John's cutting guide, or the drill, or the cutting guide where you see on the plastic in the screen. And that's my osteotomy marking on the lowermost area of the slide. That's the amount of bone which had to be removed. And this was done with the help of the cutting guide. So what I'm trying to give a message here is 3D printing is here to stay. No matter what we may say that you have to have a lady's finger for dissection or for doing your surgeries, 3D printing will be there with the surgeon to make and aid the surgery much more easier. That's the appearance of the girl post-surgery. Now coming down from there, this is another patient who came with an asymmetric face where he had a protruding jaw. And we did the similar plan with John, a computer-guided plan where John said, let's go ahead and enhance the beauty of the face by moving it forwards by 3 millimeters and setting back the lower jaw by 7 millimeters. The distinct advantage what we have when we use 3D planning or 3D as an aid for us is we can understand the anatomic location of our osteotomies. We can also understand the nuances what the surgeon would face with regards to the posterior maxilla, where the pterygoid plates have an important role to play. When I say pterygoid plates, it's that particular area which the maxilla attaches to. And these are the 3D printed guides which help us in repositioning the upper and the lower jaw. That's the transformation, what you see from here, from the left of your screen, coming down all the way. The patient was from Bangladesh, very happy. He was able to articulate, he was able to speak back. So my surgery was easily achievable thanks to 3D printing, thanks to John. Whatever success we have gained is the teamwork of the biomedical engineers. Dr. John Nason, being a maxillofacial surgeon himself, has an understanding of what the expectations are from the surgeon. That's where the conjugation of 3D printed biomedical engineers and doctors come by. These are few patients who came down from Malaysia. He had a long overgrowth of the lower jaw, subjected to a 3D planning, similar plans taken up, push the maxilla or the upper jaw in the front and a differential movement for the lower jaw. And that's where the mandible goes back. When you do these particular planned osteotomy cuts on the 3D models or aided by the computer, you can exactly know how much of the movement is happening with regards to the mandible, what's happening at the basal border or the lower border of the jaw, whether there is going to be a step. We would see this clinically, but with the advance in 3D graphy or 3D printing, we are able to give predictable results to the patient and lessens or shortens the operating time. We also planned for a genioplasty where the chin would move up in a counterclockwise direction. But however, I didn't do the chin, but that's the physical appearance and the transformation what you see with this particular patient. Coming down to jaw reconstructions, when I spoke about 3D reconstruction and 3D graphy or 3D printing, it's not only restricted to maxillofacial trauma or road traffic accidents. We find their use not only in trauma, in pathologies, head and neck oncologies or cancers. We find their use even in temporomandibular joint reconstructions. This is a young boy, 19-year-old, came with a massive tumor, what we could term it as ameloblastoma. And the plans were sent to the Biomed Academy at Atlanta, Jacksonville for planning. And that's the beautiful plan which was given to me, saying that this is what you can expect after a 3D planning. Here you see on your slide, the utmost care what is being taken right from 3D printing to the final prosthesis. What you see on the upper quadrant is the prototypes which has been given to me, as well as the amount of bone which needs to be removed when we do surgeries on these patients. And the intricacies of 3D printing and planning is so good that he would give you the size of the screws which are needed to be placed onto the bone without endangering the important structures in the lower jaw, as well as the measurements which have been very precise. That's the glenoid fossa component, what you see in the whitish color, which is made up of ultra high molecular weight polyethylene. And that's the lower jaw, which has been 3D printed. And that's the full titanium temporomandibular joint prosthesis. You see the fit. This is what the surgeons want. We need to save the operating time for the patient. We need to understand, and we need to have certain models which we can play around with in the operating room, so that we know that we are precise without having to compromise on the surgical practice. That's the transformation the patient had. And if you see at the early change, he had the fullness on the face, and that's the X-ray which clearly shows or depicts the 3D model and the final prosthesis. This is another patient operated elsewhere, came back with the hanging plate there, requested for me to do possible prosthesis. John was my messiah. We sent him the CT scans. He fabricated this particular STL model. And then on the STL model, we sat down and possibly thought of a design. Today, if I have to look back into these cases, which are 2 to 3 years old, we have reformed a lot based on the STL model findings and, of course, findings from the patients themselves. The main reason why I'm telling this is because we try to mimic the left side to the right side. But you also need to understand that when you're planning for these kind of rehabilitation maneuvers, you need to look at the intricate anatomy of the skull base. When I say the skull base, it's the base of the skull which has important anatomic structures, where you need to see the roll, yaw, and pitch, as well as the pitch of the glenoid fossa to understand if the design is going to sit well. That's the transformation, what we see in the patient. And this is another case who had a missing lower jaw. In our terms, we would term it as TMJ ankylosis, where the patient never had a lower jaw. You see the patient presented with severe sleep apnea. He could not sleep in the night. All the parents would complain is that this boy would get up and he would sleep in the daytime in the class. So we planned for not the conventional surgery. We thought that we would need to give him more. So John planned it for us on the 3D model, sent me an STL model, and then we planned to do the surgery. Even prior to the surgery, we took up the principles which were laid down by Lisrow, and we spoke about what is called as distraction osteogenesis, where Lisrow believed way back in the 1920s that gradual stretching of a bone which is fractured can lead to bone increase. Lisrow started his experiments in limb lengthening procedures, where he increased the length of the leg in patients who had shortening. And this is the same principle what we used in the maxillofacial area or the face. And that's the distractor which was manufactured by the Stryker company and the stereolith model by John himself. And we fabricated a stereolith model and a template which would render our surgical practice much more easier. This was the phase 1 without any surgery, but a surgery to place the distractors. You see the amount of bone deposition which has happened in the CT scans on the lateral view. And then I called back on John, asked him for another STL model to plan our joint replacement. That's the time we planned our joint replacement on the STL model. And this was the first surgery which was funded by the government of Karnataka in Manipal in India. And today the patient has a fantastic appearance. We also did a genioplasty. You can see his facial appearance we have traveled a long distance. That's before the distraction, after the first phase, and that's the last phase of distraction. You can see the conventional transformation of what has happened. Thanks to 3D modeling and 3D printing, that we are able to assess and show the patients what they would look like in the coming days. This is another patient who came to us with similar complaints. We fabricated a plan with CTARs from Chennai. We designed these indigenous models with the help of John. I think I've been eating John's head for the past, I and Dr. Mustafa, I should not forget, my colleague, whom we worked together as a team, along with the biomedical engineers, as well as John himself, where we planned the movements for the lower jaw. When I say plan the movements, remember in my speech, initially I spoke about 3 terminologies. That's the roll, yaw, and pitch, where how much of the lower jaw has to go down. When I speak about this, when we plan these surgeries with the conventional X-rays, what we take in the dental school or the dental college, these movements cannot be predicted at par with the 3D models. That's because on your 3D models, on your computer generated images, you can predict the amount of movement which happens when the upper jaw goes forwards or superiorly and the lower jaw comes forwards. This can be done only with 3D printing and 3D technology and virtual surgical planning. That's the patient who underwent the surgical practice, good mouth opening, and that's her transformation from where she came. She's still scheduled for a complete oral rehabilitation. I think I'm sure John has an answer for me with regards to the complete oral rehabilitation as well. This is a case which I operated a few days ago. Patient with TMJ ankylosis, restricted mouth opening. It was an extensive surgery which went on for 12 hours. We planned the surgery along with the 3D printed models, the prototypes, as well as the cutting guides. There you see the TM joints being fabricated, as well as the fossa components which are marked in brick red and pink, and the lower jaw prosthesis being there. And another innovation what John took up at this stage on a combined note, if I can add, is that we went in for a titanium bar in the upper jaw. Remember, this patient was already operated once for fractures in the upper jaw. But however, since we were going in for rehabilitation of the lower jaw, she had a cant of occlusion, or the upper jaw had slided down on one side. So now going in and removing these older plates and fitting in newer plates would be a challenge for us because there was lack of bone there. So with 3D printing and with virtual surgical planning, we were able to understand which were the areas with good bone density which would take in the screws for the bar. And the bar was designed in such a way that it would sit on sound bone. So we went in and did this particular planning with the titanium bar in the upper jaw. And this was the final appearance of the titanium bar, as well as the 3D printed and the virtual surgical planning for the TMJ prosthesis. This is an intraoperative picture or an image which is taken from the C-arm during the surgery to understand the positioning of the joints, and that's the mouth opening of the patient to understand the success of the surgery. I have not put in the immediate post-operative photos of this particular patient for the very reason that there's a lot of edema, there's a lot of swelling. So I didn't want to really project that particular image. These are the intraoperative pictures. The reason why I put up this is the accuracy of virtual surgical planning. And possibly I have to thank John at this stage, not because of anything else, but he has traveled that extra mile to learn, not from me, but mentors all over the world. I share my knowledge. I also have to thank my other colleague who works with Arjun. I'm sure Arjun would take this up on himself as well. Pramod Subhash and Dr. Mustafa, my other colleague, where we work as a team, as a unit to understand what would be the best solution for these kind of patients. These are some of the patients whom we have done a craniofacial surgery, a multiple sutural synostosis, where you see that there is some amount of slanting in the frontal bone area, as well as you can see that the bone is redundant on one side. It's a classic case of multiple sutural synostosis done in conjunction with the neurosurgeons. And here John had to play an extensive role in the computer-generated images and three-dimensional planning of the osteotomy. This is a new area for all of us. And I'm sure John is going to pick it up in no time to come. And this is the surgical practice which was taken up. And that's the final appearance. And this is another child who came to me with a unilateral anterior plagiocephaly. And those are the measurements which I took from my dear friend Pramod Subhash. And I and John sat back and possibly planned this on the STL model. So if you see the array of cases, what I have depicted, what I want to convey at the end is to say that virtual surgical planning along with 3D printed models is here to stay. Without these, it's not that surgery is impossible, but attaining accuracy, saving on patients' time, as well as reducing the operating time is what we are looking at. These are the surgical images of the osteotomy and the assembly of the bone by keeping the bone there. And these are the final figures where we come across and fix them finally together. That's the frontal appearance of the child. To conclude, I would only have to say one thing. that 3D printing is here to stay. It is fascinating. It only requires an extensive understanding for the surgeon or the maxillofacial surgeon to have an understanding with his team consisting of the biomedical engineers. It is essential for the surgeon to plan and not leave the entire process of planning to the biomedical engineer, because for the biomedical engineer, this is something new. But when you have a same level of frequency existing between the biomedical engineer and the surgeon, the final beneficiary is the patient himself. Thank you very much for patient hearing. Thank you so much.
Thank you so much, sir. You truly are the Lion King of the craniomaxillofacial jungle.
You're being very modest. You're being very modest. Thank you so much.
I think it was an excellent presentation with the wide array of cases. It basically shows. I think if we were to show all the cases, I don't think we'll have enough time on the platform. This just depicts the different applications for people to see. And everything, though it looks very easy here, I think the sir spent a lot of time planning each one of his surgeries, and a lot of team effort goes into it. But ultimately, it's a surgeon's skill. So I think the message that you conveyed is great, and a wonderful presentation with an excellent array of cases, which depicts that yes, whatever things which most say are only in theoretical knowledge, we are actually doing it in India. And we are going forward with this. So thank you very much, Abhay sir. Again,
thank you, John. It's been a pleasure sitting with all of you, sharing my knowledge. And I'm sure days are not far that when we can exchange our knowledge with Dr. Godfrey and Dr. Leroy. I think the Canadian Association, if I have to congratulate, I was in Canada, Toronto, where I worked with the Trinity Hospital and Millennium Hospital, as well as the University of Toronto, where Dr. David Sutka is one of the leading TMJ replacement surgeons. The amount of planning which goes into this particular aspect of virtual surgical planning is what I picked up from him. And I think today, if I have to ask and speak, John is doing an excellent work for India per se. And I hope with the collaboration of the Canadians, that's Godfrey and Dr. Leroy, we can give a better life for our patients in the future. Thank you so much.
Thank you so much.
Thank you. Okay, I think we're just running a little bit on time. I'll go on to our next presenter. Another prolific person, Professor Dr. Johnson Raja James. Sir again has traveled with us a long journey from the time he started. And he needs no introduction in the area of dental implantology. He's a global leader. Again, he's a professor and vice principal of Rajas Dental College, and he's also the managing director for Implantry International Dental Hospitals. Sir's area of interest includes a lot on lasers and advanced implantology. Today, there is no course that will happen in India without on pterygoid implants or on zygomatic implants without Johnson Raja's name over there. So I'm glad that we are associated with him. His pioneering efforts in the field of zygomatic implantology aims at reaching out to this cutting-edge technology to the masses. He's perfected the art and science of offering zygomatic implants as a treatment option for patients with highly atrophic maxillas as a daycare procedure. Probably less than 2% of implantologists globally actually do this, and he's one of them who does it. He's an internationally certified mentor for extra-maxillary approaches in the zygomatic implants and has trained more than 200 plus surgeons. His desire to share his knowledge and expertise in advanced implantology led him to start Implantry, which is a state-of-the-art training facility. And he's a Young Achiever Award, and he's an Asian Dental Excellence Award awardee by the Honorable Governor of Tamil Nadu. You can go on and on by Dr. Johnson Raja. We work with him very, very closely, and for us, it's always a pleasure. Johnson sir will call him, John, I'm sending you a case now. Get it ready. That's all that sir would do. And so we would sit and with him and sit and plan with him. Actually, the first implant guide, the zygomatic guide in India, was done under him. It was his concept, and we were able to do it first time in India. So Johnson sir, over to you to share your experiences. Thank you.
Thank you very much, John. John, if my screen is on?
Yes, so your screen is on.
A beautiful presentation by Dr. Kamath. It revealed to me the other side of you, John, because I've been, you know, how I've been pestering and behind you for all my zygomatic planning. But seeing you involved in so much life-changing transformations with wonderful teams around the world has given me huge respect for you. Actually, I should because should appreciate the efforts you guys take, and my sincere appreciation to Dr. Kamath and Dr. Dan from Canada. Life-changing work, actually, life-changing work. How many lives have been touched because of 3D planning? And thank you again for this wonderful platform. My presentation today will be a quick presentation, maybe one case, and how 3D planning has changed the way we do exclusive zygomatic implants. Okay, and as John rightly told, the way back about maybe, if I'm right, 4 years back, when I've been into the field of implantology, zygomatic implants for the past 6-7 years, and then when we perfected the technique, we wanted to teach it to more people. We wanted a lot of people to do, because zygomatic implants has been always something that has been done by very few people, with a lot of complications and with a lot of fear behind it. It'll go into the eye, it'll go into the sinus, it'll go here, there. So we wanted to perfect the technique and give a predictable option to the dentist, so that they also can do it on a chair side level. That was the aim. So we had I happened to meet the CETA's team in a presentation in a lecture, and then I sat with them and we had long discussions, and we did the first case in my alumni Raga General College with under my HOD Dr. KV Arun, and it came out really well, and there's been no turning back after that. We have done a lot of cases, and we have been training. We have trained almost more than 200 dentists across India and the world in the field of guided zygomatic implantology and pterygoids, and it has been a wonderful journey, and looking forward to more innovations and experiences. So my presentation will be on the minimally invasive guided protocols in zygomatic implantology. So a hot topic, and how this has now turned out to be an traumatic experience with very little surgical invasion, and then we are also able to give a predictable process solution to the patients. I dedicate, as always, my presentation to my dad, because he was the main inspiration for me to become unique in whatever you do. So when it comes to restoring the atrophic maxilla, when you have zygomatic implants in your armamentarium, you can manage any kind of case. You can say, okay, doctor, we can go with this, and I would not have to turn back any patients because of lack of bone. So out of all these techniques, I still think of going for zygomatic implants, because it saves us time. Zygomatic implants give us an option where we can go for immediate loading protocols. Yeah, and we don't wait for graft to integrate or sinus lifts and iliac crest. It's not a very invasive procedure, actually speaking, when you compare to go for the grafted solution. And there are a lot of evidence behind them, both for and delayed loading. And the good point is, zygomatic implants work better with immediate loading concepts. So with wonderful scientific backing behind that, this presentation will be brief on why we need zygomatic implants, and focus more on the minimally invasive guided protocols. 3 sets of protocols we have created for going ahead in these procedures, and I'll show you some guided surgery presentations also. This is one protocol I've been working on, but then this presentation today will not cover the extensive on this, because why I stress on the tall end cortical implantology, because this has helped me work with my 3D planning team to deliver predictable implant options, right from single implants to advanced implants such as spherical and zygomatic, into a correct anatomic guided position, so that you don't falter, and we are able to get bicortical anchorage in these kind of cases, and which adds to the long-term stability, patient success, and better ROI for our dentists. So this is one protocol, but I'm not going to talk about this today, because this is a lecture by itself. So here you can see, this is the case we're going to discuss today. You can see an all-on-4 on the lower, a tilted implant concept for rehabilitation of the lower atrophic mandible. And upper, we have done 2 nasalis implants, 2 pterygoid implants, and 2 zygomatic implants, and 2 pterygoid implants. Okay. So the MIG protocols, we have 4 important concepts. So it's totally digital preoperative planning. The more time you work on the with John and his team and the radiologist, the less time I have to do on the chair. So what happens is I can complete an all-on 10, an upper, as I said, the same configuration is all, like this is an all-on 10 configuration. Okay, so 4 implants lower, 6 on the upper. The same configuration when I go with complete planning, I can do it chair side within maximum time of 1.5 hours. That is why I'm able to do it under local anesthesia. With minimal invasive flap designs, no extensive flaps and cuts, so there is less post-operative pain, swelling, edema for the patient. So again, I can go for immediate loading protocols also. There's not much less bone remodeling, much less soft tissue remodeling after the procedure. And the implants also we place using guides, which can be partial or fully guided. Okay, it depends on what we do. So this is a minimally invasive flap design we use for accessing the zygomatic bone. It's called a flying pan design, where there is a midline cut, a slant, and then goes little remote to the parrot, and then again a crustal incision. Yeah. So just to position the guide, I do not have to reflect completely to expose the zygoma, which otherwise I would need to, because I have to visualize the guide. But when I do a guided procedure, I don't have to expose the zygoma completely. Just to position the guide is what I need. So this is how it looks like after a detailed planning. This is how my guides look like. We either go for a freehand procedure, which I don't do right now, even for my cases, and I don't teach my students also not to go freehand, go guided. This is a positional guide where it just gives me the position of the zygomatic implants. Whereas this is a partial drilling guide where I can also drill through the guides and up to implant placement. Okay, I'm not talking about fully guided systems because they're a little expensive, but we are in the process of creating right here. I'm sure within maybe 2 or 3 months, we'll be going with the completely guided protocols with my team, with my CETAS team. So why minimally invasive? You can see over here, sorry for the sound. You can see here the zygomatic implant is placed and the sinus is intact. That is the kind of precision you can get with guided protocols. Totally non-invasive. So imagine having a zygomatic in place with the sinus intact is something really amazing. It eliminates a lot of complications, right from sinusitis, sinus pathologies, pain, swelling. So a lot of post-operative and operative complications are eliminated because of our guided protocols. So what does the guide tells us? Now, when you do zygomatic implants, and those who have done will know that we have to have 3 important points. First is point A at the crest, point B where we enter into zygomatic arch, and point 3 is the point of exit. Now, all these 3 points are decided by the guides. When you plan, you can decide these guides. So I don't have to reflect all the way till here. So when the guide is in position, I can just drill through with precision without staying away from the orbit and on the infratemporal fossa. So all my anatomic limitations also are clear. Okay. So this is a brief on how I work with John. These slides I got from him only. So how we work. So first we convert our data into a 3D planning, assimilate the actual jaw position, the thickness of zygoma, the width of zygoma, everything I know pre-operate. I don't have to be I had not been surprised on chair. I have. So I can also go for STL model printing. I can do a mock surgery on my models. I can be very sure of the lens, okay, so that I can get a maximum. BAC is very important in this bone implant contact, because when you do zygomatic implants, the only area of contact is going to be this 13 millimeters. So my planning has that I get maximum BAC because there is not any bone anchorage all the way from here, the huge cantilever over here. So this BAC is very, very important. And also prosthetically, the anterior posterior positioning, right, as anterior and as posterior as possible. This positioning is also very important. Otherwise, I might have problems with my prosthetics and cantilevers also. So this planning helps a lot in these 2 aspects. So this is how we do the planning. We have simulated zygomatic implants in our armamentarium, in our library. So we place it. I work a lot with Norris implants because Norris implants are suited for the extramaxillary technique. Again, the chair side procedure. Okay. So we do the planning. And then this is the final stents we have. So these are, I told you, 2 kind of stents. First is our positional guides and the partial guided system. Yeah. So this is the, as Dr. John was telling, the first guided zygomatic implant case we did. We did about 4 years back. After that, of course, a lot of people have started with guide, but I assume this is the first guide in India. So he was there with me, guiding me, helping me through this first case, and we have refined our technique. This is something we did recently, guide for a quad zygoma case, a very challenging case for a patient who had only one eye. Okay, so this is how we proceed. So what we have to observe here is this depth, the trajectory, how much of drilling I will do on the crest, and then my point of entry into zygomatic arch. And then when I do connect these 2 points, naturally I'll be somewhere over here with exit. So I have very high precision in my zygomatic. I don't have to be scared of my angulations that will go into the orbit or go into implant pose. So those things are very clear for me when I go for a completely guided protocols. So this is the implant planning level, how we position the implants, and I see the anterior post positioning, how deep in the pad has to go. All this planning I can do over Team Viewer. And sometimes I just like to go sit with Arjun and John in his office, sit over there, do some discussions, see things. So this is how we do the planning. I don't think I have time to show you the complete video, but we can just simulate everything over here. See the transparency, check how much depth it is in the zygoma, the medic bone, all simulations you can see. I'll rush through this again. So once the guides are in position, this is a printed stents. So we'll go into a couple of cases. I'll end with that. Okay, so my anesthesia, and see the flap is raised. You can see this is all I have raised in the flap. This is a quad zygoma case. So the stent is in position, and my initial pilot drill to mark the point D. I told 2 points, right? Point A, point B, point C. This point I mark first, and we do the drilling. Once the point A and point B is done, you can see we do the drilling. That's all I need. Okay, the drilling again done. You can see the sinus is intact. So my drilling protocols are so precise and planned so that my guides help me on that, so that my sinus is intact. So the drill orientations, I can just check extra overly so that I don't make any mistakes. When you go on to the sequential drilling, we have three level drills. This is not a lecture on zygomatic implants. I'm not explaining the surgical protocols. I want to focus more on how my 3D planning and printing has helped me to perfect my techniques. So my drillings, and that is the implant being placed. That is the zygomatic implant being placed. Okay, with very high precision. Then the right side, okay, and you can see how exact we have got. See the same positioning on the planning, and this is the same orientation we got on the patient. So that is how precisely my guides can help me in simulating the actual patient position on chair and before itself. So I know what I'm going to do. I'm not going to falter here and there. Good. And this is very important, zygomatic implants, because especially in quad zygomas, because we have very little place to go plus or minus. We can't do that. We have to very bang on target, especially in quad zygomas, because you can see this is all we have. This is all the width I have. So you can see the width is this and the height. This is all the height I have. So I cannot afford to make mistakes, because in zygomatic implants, once you drill, you will have to place the implant. You cannot change positions and then remove and place the implant in a different location. You don't have space for that. Okay, and then once you drill and you go wrong, that area is gone. Now suppose I make a mistake over here, this area is gone. Then I can place only one implant over there. My entire treatment plan changes over there. See in this case, so much atrophic maxilla, I cannot place any implants anteriorly. I have to go for 2 zygomas over there, and that is why I do not touch cases now without guys with a wonderful back-end team I have. I don't have to think otherwise. That's the implants in place, the multi-units, and I think I have a post-op. I'm not showing you the graphing part. Yeah, that is the implants in position. You can see here the how precisely we have kept the 2 implants within the body of zygoma. Yeah, that's it. Yeah, good. That's the final process. So we'll see one more case where the first picture I showed you. Okay, so the all-on 10 protocol. So this is the guide system we have created. Better to have 2 split guides, because there could be any errors of placement. Yeah, so this is the guides for 2 zygomas, 2 pterygoids, and a nasalis implant also. So we can all do all the planning on the STL models, and that's what we have. So that's the upper, and this is the lower, highly compromised ridge again. So see how beautifully we can do a flapless procedure over here using tissue level guides, not even bone level guides. So flapless tissue level guides for doing an all-on 4 and lower. Of course, the limiting landmarks will be our mental foramen. So the guides in position, my initial pilot drills, voila, that's all. So you can see the 4 positional drills we have done, and then I remove the stents and go in for the sequential drilling of implants. I go for some more drilling again. So the implants in position, I check. This is something I use for getting a tactile feel or that my bone is good. I have not taken, see, it should be, of course, you can take check x-rays, but I have not taken any check x-rays because I'm so confident of my team in CETAS. So implants placed with very good stability, and that is all. When you do such cases, the patient is so happy with your precision, your management, with the nil post-operative complications that they keep coming for more. You get a lot of referrals. You can create a name and brand for yourself. That you go to this doctor, he does the cases like this. So that's the multi-units in position, and that is the all-on 4 on the lower. You can see. Okay, this is the post-op CBCT, and that is how you can see. This is a video, if I'm right. Yeah. You can see my implants clear of the nerve, the metal foramen. Yeah, and very good anterior posterior positioning. So safe procedures. I didn't have to raise the flap. I didn't have to visualize the mental foramen, and all those steps were not. This was done maybe in a matter of 25 minutes. The lower one. Okay, the upper. So this is an armamentarium. As I already told you, I work with the Norris medical companies closely. I am on their KOL team. We do a lot of planning together, a lot of programs. So that is it. My minimally invasive guided protocol for zygomatic implants, the flap design, then the drilling. As it's now clockwork now. And once I have the planning done, the guide set, it's now same thing. The pilot drill, then my sequential guide drills. And then the twist drills, you can see I always check for bone so that I know I'm drilling properly. So my drills 1, 2, and 3 if necessary. I see the length. This is my depth gauge for measuring, and that is the implants in place. When I remove the stent and place the implants. Okay, see, very beautiful. You can see my precise at the crest and right into the zygoma and the multi-units in position. So that is the left side, and then the right side again. Pilot drill, guide path, and the pterygoids, twist drills. It's the same sequence. So once you are sure of that, otherwise, no, what happens is we're not sure of the positions. When you do a twist drilling, no, these drills you're do it very slowly. You're scared it's going to the left or the right. You're not sure of the positions. Whereas once you plan, you're back on target. So get the depth gauge again, and that's the implant with placed with very good primary stability. Then the multi-units, the pterygoids and zygomas. So any kind of multi-unit corrections we do towards the end to get good parallelism. Good. So this is the end result. Very beautifully placed nasalis, zygomatic, and pterygoid implant, all guided positions. Yeah. Good. So this is the final result of the all-on 10. So upper 6 implants and lower 4 implants. This is the post-op CBCT, and this is how it was pre-operatively. And this is how it is post-operatively. Good. And then this is the final processes. It didn't matter of month itself. Okay, we waited for some time for soft tissue healing, and we went ahead with the final ceramic process. See, word of caution. Of course, I give this word of caution to all my team. In spite of however well planning you do, always keep a surgical eye open. Okay, deviations can be there because of from the patient point of view. He may not open the mouth properly. Your drill might go left or right. But if the stent is in position and you're doing it very precise, in spite of that, patient might have a small jerk here and there. So always be very, very careful about that. And I take this platform to thank the organizer of this expo, a wonderfully well-planned expo, and the software is amazing. The way you guys, because I used to Zoom and some platforms, this platform is really good. So something a new revelation for how we can take for our programs. Because John, and some doctors, we do a lot of virtual workshops for advanced implantology. So all of you are welcome to Chennai. So John is there, I am there. We see a lot of international faces. I'm sure we can have a in-person program soon. Dr. Shibu will be, I'm sure will be glad to organize a conference soon. So we'll be glad to be part of such. So it's enough of online. I think we have to start working on the offline modes, John. Yeah.
Yes. Sir, yeah. Yes. Truly, sir.
Yeah.
Truly.
So we do have a lot of programs also, and I welcome all of you to join. So because of 3D planning, because of this team I have now, placing a zygomatic implant is as easy as putting a flag in my pocket, just true and true. So thank you. And I rather than about the presentation, I take this platform to thank Sitas, John, Arjun, and the entire team for being with me through this journey and taking my practice and my platforms to greater heights. Thank you.
Thank you so much, sir, for the wonderful presentation. Actually, Johnson, sir, he doesn't need a guide as such. To honestly speaking, both when you looked about Johnson's presentation, he does most of the work himself. My guide is only as just a stop there for him to just have a look at it. Based on the plan itself, he will have a look at it, and then he straight away goes and shoot.
But agree that it has helped a lot of the freshers, those that would start the programs, very thankful to us, because now they've gone on to do implants with a lot of confidence. So that is a big thing for us, our team. So we should thank for us.
So, sir, that's very important, because it's.
John, are you taking? John, you're there?
Yeah, doctor, how can I help you? You need to
presentation is done, Shibu, and I think you can go to the next presentation. I think John is suddenly off track.
Yeah. Okay, thank you so much, doctor, for your insightful presentation. So, then invite Professor Dr. Ganesh Koniru, please, to start his presentation.
Yes.
Thank you.
So, can everyone see my presentation?
Yes, doctor. We can see it.
You can see my presentation? Well?
Yeah. It's on.
Yeah. Good evening, everyone. And it's high time that both technical and clinical teams come up together. And fortunately, it happened today for good. And I'm so glad and excited for sharing such a platform with the person who introduced me to this technology. And he was the one who explained me 2 years back. I'm relatively into this using customized 3D implants for maxillofacial surgery. Dr. Abhay Kamath sir, he came as an examiner for to our college. And after showing a few cases to him, we have the privilege to discuss with him. And he gave a suggestion that, why don't you try a 3D? That is where he introduced. He is my guru, and because of whom I have been into 3D today. And I'm also thankful to John Mason sir for giving me such a turning point in my surgical practice. Most of the time it was a laborious process involving plastic surgeons, a double team approach for reconstructive maxillofacial surgery. And every time I come up with a problem, and he would only ask me, and it would only take not more than an hour. And every time it was only an hour of discussion, and I always got what I needed, and often more. Okay. And it's my privilege for such a wonderful opportunity from the organizers. Okay. So let me put across how my life has really become easier with 3D help. So of late, I have been doing these cases for the past 2 years after Abhay Kamath sir introduced this to me. So almost 9 cases I have done so far. We have faced one bitter failure with which we went ahead in so much of changes in planning, surgical planning and 3D planning also, considering so many factors, right? So where does 3D implants stand today in maxillofacial surgery, in my perspective? Are there, it can really make a microvascular obsolete in today's world? That's always a hot debate, and definitely there are merits for both. Definitely both. So where exactly we want to use microvascular free flaps? Post radiation, any malignancy mandating an extensive resection and needing a post surgical radiation, we would always prefer a free flaps. And composite defects of oromandibular complex, wherein there is a malignancy and we're cutting down two different aspects of tissues, wherein soft tissue and bone together with a clear margins. So it becomes a composite defect. And that poses a definitive challenge right now with the 3D. Okay. And chimerism possibility. We can take a bone flap from some free fibula and we can take an anterolateral thigh flap for soft tissue reconstruction of. So there's a lot of chimerism and tissue matching is quite possible with microvascular free flaps. And in past 10 years of my post-surgical, post-graduation experience, surgical experience, I have seen 2 patients, even with a titanium allergy. I have referred to a higher center for further kind of research into that. So fibula. So 15 to 20%, literature says 15 to 20% of weight load of that side of the leg is taken by fibula. Of course, torsional forces lost a lot of muscle attachments. Over time, technique was well refined with minimal complications. Problem comes in exactly long-term follow-up rehabilitation, long-term rehabilitation follow-up cases. No, prosthetic journals totally say that we encountered 40% of implant failures. No, surgical journals quote that our success rates are almost 98%, 97%. There is minor conflicts in the literature from 2 different perspectives, prosthodontic and surgical perspectives. So where exactly we come short in free fibula grafts? When we take a single barrel bone stock, so it becomes kind of very suboptimal for prosthetic rehabilitation. And in case of double barrel, I always wondered looking at the OPG or scans, say 2 years, 3 years down the lane, there is always a problem with interface osseointegration. So it's like bent over bone on bone to achieve that amount of vertical dimension. Always there is some probability of failure of osseointegration at that interface, double barrel interface. And previously, there are articles supporting recon plate anchored fibula. Of course, that leading to a lot of stress shielding effect. And they have shifted slightly onto your mini plates. So what is more bothering for me is occlusal loading. When a long bone, though it's coaxial, hardly takes 15% of the weight load on that side of the leg, but still its haversian system is so well tuned, like it appears as a carom coin pile. It's a carom coin pile, and when we are subjecting it for a horizontal, when we're positioning it in a horizontal and loading upon with a perpendicular occlusal loading, there are always a possibility from ranging from peri-implantitis to total implant failure. That's what I have encountered in, say, 4 out of 10 cases in our institution, with a lot of help from plastic surgeons and prosthodontics and everything. Still, maybe we're too naive and we need to evolve a lot. That's that aspect too. And even after sectioning the fibula, we tend to see that edgy contours, though it's a very minor problem though. And one more option for us for mandibular reconstruction would be deep circumflex iliac artery flap. A contralateral harvest would be a better option for angle involving defects involving angle. So where do we have this? What are the pitfalls we encounter in a DCA flap? A morbidly obese and gestational age group females. And whenever we harvest a DCA flap, we need to go for a mesh reinforcement for preventing abdominal herniations. And Miralgia parasitica in almost say 2 out of 4 cases who encountered neuralgia parasitica, and it's post-operative ward duties, auscultating for borborygmy, and finally hearing that would be such a borborygmus relief for a duty doctor also. So, where is the rationale for using titanium prosthetic jaws? The first patient who has motivated me to look beyond a regular microvascular flap is an unmarried 21-year-old girl. So young girl, very beautiful looking, but still Savamatoid variant of ossifying fibroma, attempted curettage elsewhere thrice. It was progressing very fast, and there is a cortical destruction. And that particular case where I went to Abhay Kamath sir, where he guided me into this 3D process. Beautiful things about titanium prosthetic jaws. Absolutely no donor site morbidity at all. No second site surgery and scar. More readily compliant. So whenever I can explain to my patient, yes, I have a second option. One would be your natural source, your own source, and one would be this one. It comes with some hitches though. You need to give a consent. You need to go for some allergy testing. So whatever it is. So still, scarless, no second site surgery, and that's become readily compliant with younger age group. And such a pre-contoured jaws, prosthetic jaws we get, absolutely symmetrical with the help of mirroring images. So immediate dental rehabilitation is definitely a possibility, and obviously titanium is biocompatible. What comes in handy as an unspoken bonus is the tools, starting from stereolithographic models to surgical guides, cutting guides, everything comes in a package. So big thing comes in a small package. So whenever I used to get a courier from Sitars, it's such a small one, but I could get so much out of it so that I can use it for patients' education and surgical accessories also. And it really made my life easier, and it helped my PGs to understand a lot better. It improved not just my confidence, me operating 9 cases and they assisting me. Now third year PG could easily feel that he could operate. The moment he steps out, he's ready to operate on his own. That kind of confidence, that kind of surgical accessories do come in this small package. And what is more important is time saving. Almost, it has reduced to 3/4. Say free fibula with 2-team approach, it almost took 8 to 9 hours, sometimes 10 hours. Now, entire resection, plating, putting the process inside and screwing and fixing it up. Everything would take almost 1.5 to 2 hours maximum initially. Initially, I took around 2.5 hours. Now I have cut it down to almost 1.5 hours. So it's just cut and paste. The problem where it really helped, this prosthetic jaw really helps, is not every hospital. I work in a tier 2 city. Sometimes I'm forced to work in a small town with only one hospital in that particular area, and anesthetists cannot stay more than 3-4 hours. They need to rush for their hospitals to a bigger city, neighboring bigger city. So not every hospital is equipped though for a microvascular, and not every anesthetist is patient enough. And let us take blame on our side also. Not every surgeon's expertise for microvascular surgery. Okay, so this has really revolutionized and made life far more easier. So this was a case. It started with a normal dental rehabilitation, wherein a patient met with an accident and there's a labial cortical avulsion there and not much of bone, and he's not ready for any grafting, and no donor site. No, he's not ready. He's too young for that. And finally, we could convince him for this kind of prosthetic rehabilitation. So that is how, this is a recent picture which we have operated around 10 days back. And so prosthetic jaw rehabilitation from the dental component, let me shift my focus onto the prosthetic jaw rehabilitation. What went wrong? This case has genuinely tricked me, kind of motivated me to think more and more. This was a case I got an opportunity to attend. Completely extraoral. young age, and not happy with the anchorage there. And this patient came back 3 months later after surgery with an exposure, both intraoral exposure and extraoral. There's a breach, there's a opening, gaping of the wound there. Okay. So that has made me think more into it. So I have discussed a lot regarding this case and how I need to go about in further cases. No, failures is not the one that could be accepted in some parts of the surgical practice, what we encounter in day-to-day life. So few things I have noted for surgical, from surgical perspective. Periosteum of a bone is a very great barrier for pathological breach. It's a very great barrier. A malignancy could even sometimes take a little time to break up the breach the periosteum. And for benign tumors, periosteum is really something like a strong room for it to breach that easily. And always underestimated periosteal potential in osteogenesis and remodeling. I would show few cases wherein periosteum, placing a process within the periosteum and taking a CBCT after 6 months, it showed complete bone coverage onto the titanium. That owes to the biocompatibility of the material as such. And availability and preservation of keratinized gingiva. This one, from surgery perspective, we need to have a key eye on. And local full thickness tissue elasticity and defensively predictive tissue shrinkage. So when I discussed with John Nason sir almost 2 years back, sir, I wanted full height. I wanted a kind of nice occlusal line. I don't want any gingival component of prosthesis. I don't want any elongated teeth onto the prosthetic jaw. That is where we started thinking more and more. He helped me evolve that at least I should be prepared to accept 30 to 35% of tissue shrinkage. That was a defensive count, 30 to 35% of tissue shrinkage. So we should not be having an exposed prosthetic jaw. We don't want any resurgeries. Okay. So that is from that points we have evolved to this. So this is my first patient. So it's a salamated juvenile ossifying fibroma. So entire resection was done totally intraorally, and we have surgically, I have buried these implants, abutments intraorally. I have totally buried within that keratinized flap. Keeping the entire dissection was done as a keeping the periosteal pouch intact and placing this process inside and fixing it and completely burying these abutments, allowing these abutments, what you can see on the right side picture, up one. So they have slowly hatched in around 15 days. It took 15 days for these 3 abutments to slowly hatch into the oral cavity, and to an extent of cementable denture process. It took almost 1.5 months for this 6 millimeter of exposure, on which we have given a temporaries. Now the patient is with permanent teeth, cemented teeth. So during the planning, this was what we went through. So it was a hollow process. So we have a cut end here, we have a cut end here, we have a cut end there, and cortical on the outside and cancers inside. And cancers part should be abutting this hollowness. Okay, and this porosity, over this you have a periosteal pouch, wherein the periosteal reaction on the biocompatible material have enabled new bone formation. And after 4 to 6 months, CBCT revealed that entire this hollow component of the process is filled up with the endosteal to endosteal continuum of new bone. And whenever I tried probing with a sharp probe into this porosity, I encountered some amount of resistance. There's a bony hardness. And on close observation, we have seen that there's a periosteal reaction, and there is a bone covering 1 millimeter of bone over the process, and this entire hollowness of process is filled up with the new generate, averting cancers to cancers across the span of the surgical defect. So this was the post-operative OPG. And this last particular abutment is purposely submerged still. I don't want to open up that particular area. Anyway, patient is very happy. She's too young. She got married now, and not a single scar on face. Entire surgery was done intraoperatively, giving utmost respect to maintain the integrity of periosteum. In benign pathologies, I can take this risk. And next one would be the 3D process in TM joint surgery. So I have seen so many TM joint process which are so huge enough, almost reaching till the angle. And of course, the classification of ankylosis, the extensiveness of the ankylotic segment mandate that amount of resection, and at the same time that amount of tripoding anchorage way down till the angle. But here we have a case wherein it was only Sony's one, and we could see a lot of degenerative changes. And there was a previous attempt by someone else to try to do a discal repair, but still it was progressing. So I discussed with John sir regarding this one, and he gave a plan like, okay, fine, we could minimize, sir. What I wanted from him that particular day, and this was the only case I remember which took only 2.5 to 3 hours of discussion, and rest of all it's hardly less than an hour to discuss with him. And this is published, and this particular case is published as GD process, GD condylar cap process. It's a half of the condylar head. It was capped with a lateral extension. The main rationale for this kind of minimization of the process is when a subcondylar fracture or condylar neck fracture, low condylar neck fracture, could very well be plated with a lambdoid configuration of plates, what we use for fixation in trauma. Why can't this be that same lambdoid pattern be incorporated into the lateral flange and make it a smaller one? And we need to replace only that condylar gap. It is around 1 year, 2 months follow-up, and patient is still maintaining 35 mm of mouth opening. He is absolutely doing fine. I am really grateful for John Essen sir for doing this kind of work for me. And this is the case what I wanted to discuss little more in detail. Now the problem is, this is also a patient, 27-year-old, recently married, abandoned by her husband in a nearby village because of her asymmetry, facial asymmetry, newly married. So we have to give her a face back, and her husband is not ready to accept a scar on her face. So again, we plan completely intraoral procedure. This time, it is a benign pathology, and we maintain this lingual osteoperiosteal flap. After initiating complete pathology, we have literally scraped down the lingual cortex to paper thin, maintaining only an osteoperiosteal, a thin lamina papulaceae kind of osteoperiosteal flap. And then we try to negotiate the mobilizing the neurovascular bundle. That's the reason you can see that grooves. One of that groove I could use for repositioning that mental neurovascular bundle there. So everything went into the prosthetic design with 35% of tissue shrinkage vertically, and then kind of what pushed me to think of this design is the pathology. The nature of the pathology was slightly less aggressive than the previous one, and there is always a possibility to preserve the natural bone, at least on the lingual side in this particular case. And teeth anyway they have to go. And the beauty of this case compared to the previous same segmental resection is the new bone. There's a new bone bridging from this one side of the cancellous bone to the other side, ramus cancellous bone, along that hollowness. And the cross section of this process is a C-shaped. Unlike a tubular process in the previous case, this is a C-shaped process. So C-shape encuffing onto the lingual osteoperiosteal flap. Now, even in the worst come scenario, in future, if there is any intraoral exposure of this one, mandating the removal of this process, I could only resect at the plating side, or if it's good enough, I'm able to retrieve all the screws and remove it. I can just avulse it onto the buccal side, leaving the newly formed bone very much intact with the lingual osteoperiosteal flap. So that would remodel in 3 months. Hopefully I can place an implant in that too. So it's taking a double call. So giving the patient a double chance. In the previous case, if there is an exposure, and it's being a tubular process, so I have to remove the entire one. Maybe I can try a couple of times repositioning the flaps, all that under local anesthesia, all that fine. But still, if there is a time wherein I have to remove it, then that segment entirely goes off back. So new process have to be designed, suboptimal, again height, everything comes into play. In this particular scenario, even if there is a chance of exposure, I could only cut the process and avulse it buccally, retaining the periosteal pouch back again, and keeping that newly formed cancellous bone abutting to the lingual osteoperiosteal flap, lingual cortex. So this was the postoperative OPG, and this particular patient, almost 8 months back we have done this, and now with a good amount of process to bite. So what would be the, I don't know, I'm relatively new to this field, hardly 2 years. So what my expectations from this 3D printing people is, we needed an integrable scaffold, a scaffold that could be bioresorbable. And eggshell powder, there is a way of making it for bone grafting issues, and institutionally there was almost 600 cases, and we have encountered outcomes of eggshell powder being bone graft used as a bone grafting after periapical surgery or a small cystic defects. We could say almost it is 90% better than most of the available particulate graft material right now in the market. And some look into electrospun fiber reinforcement. What is the problem we face from a tier 2 town would be affordability and processing time. So everybody wanted it very fast, and affordability, of course. I am really thankful to John Nesson. He every time gave me a kind of that leverage space to bargain. Anyway, thank you 3D printing for helping us give scarless faces. Wonderful job from your side. You have made our life so easier. Humble souls, yet witty as survival, ambitious for a greater good. We all here as one, hopefully rewriting reconstruction stories. Thank you, one and all.
Thank you, Dr. Ganesh. Can you hear me? I think I got lost when I was introducing. Thank you, sir, so much for the wonderful presentation.
Thank you, sir. Thank you, sir. All because of you and Dr. Abhay, sir.
I think a lot we owe to Dr. Abhay for guiding us.
He is the guru who has introduced me into this.
Thank you, Ganesh. Thank you for those kind words and an excellent presentation.
Sir,
John, as usual, thank you.
Thank you, sir.
The biggest question that most people ask, when we do titanium reconstruction, you're replacing function and form, but you're not replacing biology. But I think yours is a classical example where we are slowly trying to replace biology also with bone growth happening. So I think a little bit more studies are there, and I think with more publications coming in, 3D printed or additive manufactured solutions are here to stay. I think I missed on the introduction, like I said, like Ganesh sir is, we've known for the last 1.5 years. He's an associate professor in Sibar Institute of Dental Sciences, and he's done his fellowship in cleft and craniofacial surgery. The first time, when we met Ganesh sir and when we do cases, like most of the surgeons, like I said, they tell me, John, this is the pathology, how do we work? But in case of Ganesh sir, it's the other way around. He'll show me the case. I have to ask him, sir, what do you want in this case? Because he's somebody who always thinks very, very differently. And I'm glad I work with an awesome team with Abhay sir, Dr. Pramod, Dr. Mustafa, Dr. Ganesh, Arjun, and I'm blessed. Dr. Ruchi also over there with a wonderful team of doctors who think laterally. You don't restrict them to this conventional surgical work, but also saying how do we use technology? How do we bring in technological advances over here? And I thank you for that. Once again, awesome presentation, sir. And thank you very much.
My pleasure, sir. My pleasure. Thank you.
So I want to call on our next speaker. Next speaker is Mr. Oscar Pedro Morales. Oscar represents this company called Nemotech, and It's been a beautiful, wonderful journey with me with Nemotech. We started using Nemo for the last almost 4 months now that we've known each other, and a wonderful company. It's an emerging company in the area of digital dentistry and surgical planning. I think all of you should get a chance to get to see this. Oscar Pedro has graduated in chemical science. He's a biochemist by nature. He's an expert in the Nemotech software for planning implants and in designing of smile design. So when I asked Nemo, I wanted, because we're going to have a lot of surgeons talking on reconstruction of the bone and the face as such. But when it comes to dental rehabilitation, and especially with the Canada team there with digital dentistry, how do we work this out? How do we go on a purely software-oriented work? So Nemo responded and said, John, we have a solution. Let's look into it. So I would like to call upon Mr. Oscar to come on stage and to share his screen with us. Oscar, you're there?
Hear me? I'm here. Can you hear me?
Yes, Oscar. Please share your screen.
Okay. Can you see all my screen now?
No, Oscar, I can't see your screen.
Well, I try to share it at least.
Yes. Yeah. You came in.
And now? What about now?
Yeah. Can you just go on to the presentation alone? I can see your screen. Yes.
Okay. So I'm gonna start.
Yeah.
Thank you very much for your introduction. Yeah, I work for Nemotech. My presentation, which is going to take around 15-20 minutes, is going to be alive. I'm going to show the software. I'm going to get into the software and show you some possibilities, not all, of course, because in 20 minutes, it's really absolutely impossible to show all we can do. But at least I'd like to give you a rough idea of the possibilities and the advantages and the difference, the big difference between Nemotech and other software companies, because for the dental world, I mean, because it is true that there are many softwares for, for planning implants and producing guides, for doing orthodontic setups, or for doing smile designs, or for planning orthodontic surgery. There are others, yeah, it is true. But the product we have developed, and that's what I want to explain you and let you very clear this afternoon, is quite a bit different, and it's really make us unique in the world. So before getting into the software, I would like to give a very short introduction, couple of minutes only, with a PowerPoint. It's very long, so I'm going directly into this, just to explain you this difference. I presume you're all seeing this. As I told, Nemotech is a Spanish company, 28 years. During these 28 years, we have been developing software for the dental world. We belong to the French group Biotech Dental since last year. And the product we have developed during all this period, the difference is that we have different softwares, different models. For us, we call them models. Each model has a purpose, is conceived for one treatment or another. Planning implants, orthodontic surgery, orthodontic smile design, but all the models, in fact, belong to the same platform. The name of the platform, in fact, is Nemo Studio, and since we install one single model in a client, in a new client, in fact, what we are providing is not the independent model that this new client has purchased, but we are providing the very heart of the platform. So the difference here is that when we are going to create a patient and we are going to start importing files for this patient, which can be photographs, digital photographs, or STL models, or a DICOM tomography, or whatever, face scanner, I don't know. We are going to store all this not in the model that this client has, but in the center of the platform. So that allows us if we only have one model, in this case, I put smile design, this will give us only the possibility to do a smile design work, I mean, static and also clinic study. But if we have another model now or in the future, all the work we have done is not lost. We are going to be able to share all the files, and without leaving this patient register, we are going to be able to navigate flexibly between models and do a case which joins, in this case, a smile design and an implants planning and producing products. Okay, like a mock-up, shells, a guide for guided surgery for implants. Okay, but even if another client has more models or even the whole Nemo Studio platform, he can do an absolutely flexible case and multidisciplinary case without leaving the patient file, the patient register, and sharing all the files we had imported for this patient. Okay, so this is the big difference, and I will show you in 1 minute. This is the big difference between Nemotech and any other dental software in the world. It is true, there are other softwares for implants, there are other softwares for smile design, there are other softwares for orthodoncy, but there is no any other solution in the world giving you the possibility, without leaving the patient and sharing the files, to do a flexible and multidisciplinary case. So I'm going to now leave the presentation and go directly to the software to show you this, because this was the concept idea I think very important to give you. So I go directly into the software, and don't forget that when I'm gonna get into the software, I'm going to get into the center of the Nemo Studio suite. Okay, I'm not going to get into into one model or another. So this is the main screen. Impossible really in 15 minutes to explain you everything, but in the main screen I have many possibilities, or at least a few possibilities. I can create a new patient. I find an already existing patient where I have already worked another day. I can import or export cases to share with other doctors or with labs or with prosthetists. But when I say import, export, I don't mean export only files, but the entire case, the planification, I can export or import to share with other people. Anyway, well, I'm going to directly into one existing patient. No time to see everything. So I'm gonna get into, in this case, a patient where I have already imported files and I have already developed a few things. In this case, what I did was, I imported the photograph, I imported the CT, the tomography, I imported the models, upper and lower model. I was able to also to segment the bone, maxilla mandible, and to change the relationship maxilla mandibular. And then I developed an implants case. I segmented the crowns, I segmented the roots also. I was able to do virtual extractions from the models or from the bone, even to put prosthesis and do implants planification according to the prosthesis. And I created the surgical guide, of course. It's very simple in this case, one single implant, but I can do introduced cases, all on 6, all on 10. I mean, many possibilities, of course. We can also create other products like endodoncy guides or guides to do an sinus elevation guided, or a guide to for cutting the bone reduction guide. And then, because I wanted, and this I will show it to you, I changed to the orthodoncy model, and with the same files that I got from the very beginning, and because I did the segmentation, I was able to do an orthodoncy setup. Let me see, because I'm receiving a WhatsApp. I don't know if it's something important from me. I presume you are hearing me.
Yeah. Yes, Oscar, we are hearing you. Yeah.
Okay, very well. So I was able to do an orthodoncy treatment without leaving the patient register. I was able to do a brackets treatment, or with aligners producing the biomodels. I could also do another product, a gingiva cutting guide. And also I was able to do a smile design, which maybe is logically it's the very beginning. And from this, I can get the mock-up and use the mock-up as a guide to know where I want to go in the orthodontic treatment and in the planning, in the implants planning. So what I'm going to do is directly go into, for example, in the smile design model. In this case, it's already a bit advanced. I already put some prostheses here. Of course, there are tools that I could show you how to play with all these. But as you can see, if I open my list of meshes here, you can see all that I have imported and all that I have done while working all around all along the case, beginning with the bone, segmenting maxilla and mandible, importing the models, sinus, and then segmenting the crowns and the roots, and then putting these prostheses that you can see here, and then we will produce later the mock-up. Being now into the Nemus Smile, and this is the model which I entered, this is what I called our magic bottom. If I open this bottom, this is the bottom which really makes Nemotech different. This bottom gives us the possibility to navigate between models and to go whenever I want, for example, here to the implants model, or to the orthodoncy model, or to the orthognathic model, and sharing all the files here that I have, all the measures, so I can go to the model that I want and do the treatment according to this model. And so I have the possibility to do an absolutely multidisciplinary case, mixing orthodontic treatment, implants, starting with with smile design, as you can see, segmenting the bone, doing orthognathic, planning orthognathic if it's necessary. I mean, and this is the big difference of Nemotech comparing with other softwares. Well, anyway, now I'm in Nemosmile model. As I mentioned, I already placed some prostheses that I can hide or show at any time for you to know. But if I show them, once we have placed them, once I have placed them, I have some tools to change, to rearrange the prosthesis according to the result that we want. We can do any dragging, any rotation. We can even change the size of the prosthesis, and we can do all these, bringing at any time we want the photograph of the patient, to do static design. Okay, let me hide those arrows. Okay, so at any time we can bring the photograph of the patient and change the position of the prosthesis according to the face of the patient to do a static study. It's not only a question to do a static study, but also to do a clinic study. So we have tools, as I mentioned before. We have the virtual articulator. At any time, we can change the relationship between maxilla and mandible. We can introduce the models or the bone, maxilla and mandible, that we have segmented previously, and we can change the relationship and then apply the relationship that we want. For example, we had an initial relationship, how we got the models from the scanner, but here I changed to the occlusion, and if I show apply, okay, if I show for example, the bone and the lower model, okay, here you can go to apply any relationship that you have created previously with the virtual articulator, okay? So why is this important? Because it's gonna give you the possibility to make this smile design not only from aesthetic point of view, but from a clinic point of view. This gave us some possibilities, some tools to change the position of the prosthesis according to the verticality of teeth verticality, the occlusion. And so being in this view, for example, you can change the position of any prosthesis also, okay? You have different tools anyway to do this clinic study. Okay, once we have theoretically arrived to the smile design that we want, remember also, as I mentioned, at any time you can bring the photograph, okay, change the transparency and do a walks-up, mixing different views, okay? And as I mentioned, once you have theoretically arrived to the design you want, and you have the possibility to add as many prostheses you want, simply choose the libraries that you want to use. You have many different libraries, so the only thing you have to do is choose the position. In this case, I choose from 13 to 23 plus 26. There was an absence, but you can change. You can decide any position, and you can even mix different libraries for different positions. You decide. You click OK, and you decide the prosthesis, and then you play with these tools. You can also have a tool to add or to delete material. I mean, you have different tools to change the design. But anyway, once you have theoretically arrived to the design you want, you can go to products and you can produce different products, okay? In the case of Nemo Smile, the 3 products you can produce typically is the mock-up, the shells. You can produce also the shells, and you can produce a flipper, which is a base to glue or to do to glue, yes, to glue the shells to the teeth of the patient. Okay, I'm going to show you. It's very, very easy and very quick. It takes a minute. So I'm going to show you, for example, the mock-up, and then what you can do with the mock-up. So I'm going to create first a bridge, for example, from 13 to 23, and then I go to mock-up. I create this bridge, and then I'm going to decide the base where I'm going to join this bridge. In this case, of course, I want to join the bridge to the upper model. I click OK, and then simply generate the mock-up. So it's very easy. You do it in 20 seconds. Once you have the design. Okay, so here it is. So if I go now to my list of meshes, at the end, what I will have is, or these are the teeth, the bridge, I mean, and this is the mock-up that I have just created. So as a STL model, I have the possibility to export it wherever I want. It's an STL open file. If I had a 3D printer connected to my computer, I could directly send it to my 3D printer, or if I don't have it, I can send it to my hard disk, and from there send it by mail to a lab to be printed. Okay, so very simply, in 20 seconds, I have produced the mockup, and I have the possibility directly to export this STL model. Other products that I could produce, as I mentioned, shells, flipper. But another thing that I can do now that I have arrived to my design and I have produced my mock-up to place in the mouth of the patient with a silicon key. Now I could decide, and this is really the big difference of Nemotech. I could decide to go to, for example, to implants. So I change the bottom. You see that Nemo Smile is going to change. Now I'm not anymore in NemoSmile, but I'm in NemoScan, which is our model for implants. So these bottoms are going to give me the possibility to do a planning, an implants planning, and to produce a guide. The same way, if I decide to go whenever I want to the orthodontic treatment or the orthodontic model, you're going to see that these bottoms are going to change in a few seconds. Okay. And now I'm not anymore in NemoScan, in the implants model, but I'm in NemoCast, which is the orthodoncy model. And now these bottoms give me the possibility to do the setup for orthodoncy. So as I already segmented crowns and roots, I can now do the setup very easily. I can drag and do the setup not only with crowns, but also I can see how the roots are going to move according to the setup. And as I have the mock-up that I got from the Smile Design model, I can move the teeth in the setup, in the ortho setup, according to the position that I want to arrive according to the mock-up. So this multidisciplinary solution is really the big difference of Nemotech, and is really our great advantage, and is I mean it's the tool which makes really Nemotech unique in the world. So this is a very, very roughly and very quickly what I wanted to explain you. As I mentioned, doing a very deep presentation would take us a few hours. I mean, at least 1 hour or 2 hours, and then training is longer. Any model, any software has many different possibilities, and explaining this, I mean, it's not the purpose of this presentation. I just wanted to give you this difference idea and this rough idea. And well, I want to stop just in case anyone wants to make a question. I will be very happy to if I can to answer to you.
Thank you, Oscar. I think it's I think given the extreme short time limitation, and you've covered and made an eye opener. I definitely would want to look at how Nemo can, because I use Nemo
Okay.
for the orthodontic. So we want to see how we can use more of the Nemo scan and the Nemo Smile.
Yeah,
design.
I mean, I used to do demos in English, in French, in Spanish for NemoScan, for NemoCast, for NemoSmile. But a demo for a single model would take us not less than 50 minutes, 1 hour. So I think that in 15 minutes or 20 minutes, the purpose of my presentation was to give a rough idea of Nemotech, and I mean the main advantage, and I think this was my goal, and I hope to arrive to well explain it.
Okay. Yes, true. Thank you, Oscar. Thank you very much. And I think we will definitely take this discussion backstage and take it forward with you.
Thank you very much. Thank you very much to all. Bye bye.
Okay. Our next speaker for the day is going to be somebody who's very, very close to me, Dr. Arjun Krishnadas. Arjun is one of the young emerging surgeons in today, in not just in the Indian platform, I think, and shortly in the global scenario also. Arjun has completed his master's from Ramachandra University. So technically he's my junior, and he's shown great content and great move. Following which, Arjun actually has joined Amrita Institute of Medical Sciences. He did a 2-year fellowship in cleft and craniofacial surgery. Currently, he works as a consultant at Amrita Institute of Medical Sciences, Kochi. And I think Arjun consults a lot with in and around Kerala and with a lot of his colleagues over there. So most people that I know of, okay, they ask me, okay, do you know Arjun Krishnadas? Okay, that is okay. Yeah, I'm his senior in a way. So, and Arjun does great job. I've seen Arjun is my contact point when we start working with Amrita. So anything that I want, I ask Arjun, and he gets the job done for us. So Arjun, looking forward for your presentation to see the awesome work that you guys are doing, and welcome to the platform. Arjun, your audio is not there. Can you make it a bit louder?
His mic is not activated now.
Yeah. Can you hear me now?
Perfectly.
Yes, sir.
Yeah. Thank you so much for the introduction, sir. I'll just share my screen first.
Yes, Arjun, we can see your screen. Yeah.
Okay. At the outset, I would like to thank the organizers for giving me an opportunity to speak on this forum. So I was given the topic on technology-assisted mandibular reconstruction options, reality versus expectations. I work at Amrita Institute of Medical Sciences, Kochi, and we work as a team with the head and neck and the plastic surgeons. So in our team, we have Dr. Subramaniam Iyer, Dr. Pramod Subhash, and that's how we operate. And these cases, it belongs to all of us. And all this wouldn't be possible if we wouldn't have worked as a team. So the challenges usually that we face in cases where you have post-ablative rehabilitation is that you usually have composite defects, and there's always a mismatch between the resected and the reconstructed tissue in both in quantity and quality. And what happens is when you reconstruct, at times you may have a deficient soft tissue cover, which leads to complete failure of the flap, and then the bone fails, and then you cannot rehabilitate the patient in future. So the issues that you usually face in hard tissue is that when you place a bone, when you resect the mandible, when you place a bone, the graft height may be less. Okay, so it is very difficult for you to actually rehabilitate. And in cases of aesthetics, when the resection margin or the lesion crosses the midline, and then you have to address the symphysis as well, you may not get the proper contour because the symphysis is actually a curvature, so you may not get the actual contour. So it's very difficult to maintain and recreate that contour. And the other thing is when you do a disarticulation in the mandible, what happens is when you replace something in place of the condyle, it may not act as efficient as a condyle, and you may end up having deviation or difficulty in mouth opening. And to address the issue in the bone height, that is the variability in the bone height, the other technique that which we usually do is do a double barrel and then compensate for the bone height loss. The soft tissue related issues that we usually see is that after you reconstruct, the normal vestibule is lost, and that has been replaced with excess of soft tissue on intraorally. So what happens is you have a lot of skin or muscle that is being placed inside the mouth, and then it is very bulky. You cannot rehabilitate the patient immediately. And moreover, once you have your skin paddle over there or your muscle over there, your original oral mucosa, that is your keratinized tissue, is lost. So you have to recreate that, and you have to recreate the vestibule as well. Once, if your soft tissue around the implant is not very good, you end up having implant issues like peri-implantitis. And then if you don't maintain your oral hygiene, again, the implants that you place may fail in future. So the options that you usually have is that either you don't reconstruct, or if you reconstruct, people usually place plates because they may not have access to a team where they do reconstructive surgery. If the resection margin is somewhere between 4 to 6 centimeters, you may go ahead with the bone graft, or you can go ahead with the microvascular free flap. So I'll just show you as to how our unit has evolved from by just using STL models and pre-bent plates to what we are doing currently. Okay, so this case was operated probably 4 or 6 years back. A small girl, probably she was only 16 years old, was diagnosed with the ameloblastoma of the mandible on the right side. As you can see, the lesion is quite big, and the lesion is very close to the condyle as well. So we have to resect, we have to disarticulate the condyle on the right side. So as a general principle, we went ahead taking the CT scan and then understanding as to how big the lesion is, and we had the idea of how much of the mandible is going to go. So what we did is, first, if you have a lesion on that side, you usually mirror the side, or you flip the side, and what you do is you have to make a normal mandible so that you can bend a reconstruction plate, and then you can take it forward. So what you do is, what we used to do earlier was, we used to take an STL model, and then we used to bend a plate on top of that. And then on that plate, we used to cut the fibula segments, attach it to the plate, so that you have an exact template as to how much of fibula is required to reconstruct the defect. And the same thing is done on table. The same pattern is done on table, and then this is what we used to achieve. You can see that the bone height is way too varied. The fibula is way too down, and then you have your mandible way up there. And then rehabilitating was very difficult because the implants would be way down. And then we used to use longer abutments so that the Paris bar, so that the entire console was supported on top of these abutments using Paris bar. So it was very difficult because, longer abutments, there are high chances where your abutments may fracture over a period of time. The symmetry, everything was okay. Everything looked very well. But then the implant positioning and the loss of vestibule was a very big concern for us. But if you look at her, she looks good. She doesn't look like she's been operated because of facial symmetry. Everything is nice. But then when you take a scan or an X-ray, you find the bone in a very different position. Another case of OKC operated elsewhere, and then he had recurrence, came to us for a final management. Same thing, we went ahead making models and bending plate, and again you can see that the implants are placed, but then this was the soft tissue height that you see, and this is obviously a concern because after you place implants, you have to do multiple procedures to take care of the soft tissue around the implant and then address the vestibule, create a vestibule. Now you can see over here, this yellow arrow shows the bone height over here. It is way too much. It is very difficult to manage this. But then we went ahead rehabilitating him, and he's doing well. This is probably 5 years post-op. He has no complaints, but then obviously, like I mentioned, longer abutments, there are high chances that it may fracture. But then the other ways to handle this is either you can vertically distract the fibula and then gain more height, and then as a third procedure, you can place implants and do a vestibuloplasty. This involves multiple procedures, and then the patient needs to undergo procedures under general anesthesia, which is not advisable. So, or what you can do is you can do a double barrel and you can place implants. But at times what happens is, if you do a double barrel and if the segment on top doesn't actually have vascularity and may necrose, you may have to take it out, and then you're left with a single barrel again. So the issues over here, one is the bone height that we have seen, and the vestibule issues. The next is a case where the patient had a lesion in the mandible, OKC, very close to the condyle, went ahead resecting it, disarticulating it, and then we kept a stock joint. We kept a stock joint on a scapula, probably one of the few cases where we have done a stock joint on a scapula instead of a fibula. So the same thing was, the mock surgery was performed on the STL model, and the same thing was done intraoperatively. But then the issues that we haven't faced, but then what we think is that stock joints are very unpredictable at times, because a bit of position change, you may end up getting less number of screws on the bone. So we were quite concerned that if just in case next time if we do and if it does not go as per plan, then we may end up just placing the bone and not the joint. So to overcome this, we went ahead and we thought of start thinking about custom joints and custom plates. So that's when we got in touch with Dr. John Mason, and we have discussed like length and breadth of how reconstruction should be done, and what problems we have been facing of late, and then how we can overcome that. So this man was operated probably a couple of months back, a case of ameloblastoma in the central segment of the mandible. He underwent CT scan. This is also a case of ameloblastoma, which is recurred again. So we made sure that it is cleared properly. We had a good margin. So his CT scan was done, and the same CT data was sent to STARS in Chennai. And then we have discussed the resection margins with the team in Chennai, and this is the plate that we had designed. So the most important part about this plate is that you see the screw holes at the top. Okay, so that will allow you to position the bone a bit more higher than usual. Usually what happens is that your fibula is usually at the lower border of the mandible. It lines at the lower border of the mandible. But in this case, you can keep it a bit more higher so that your height discrepancy issue is probably taken care of. Okay, and these holes, the lateral holes, the foot plate, it also corresponds to the holes of your resection guide or the resection guide. So this was the implant that we received from CETAS, and this is your resection guide. So these foot plates of the resection guide also follows the foot plate of your plate, so you don't have to actually lose holes. You can drill these holes on the cutting guide, resect the mandible, and use the same holes to position the implant. So at times what happens is if your resection is way too long, and if you don't have a control over your proximal segments, then what you can do is you can just hold your proximal segments and then fix this plate to that. So what happens is that your positioning is much more under control. So the implant was placed, and then the bone was your fibula was fixed onto the plate at a higher level, and then you have your soft tissue covering the fibula. These are the post-operative images. You can see that the implant has fit well. The bone is at a higher position, and not much of discrepancy is seen as compared to the earlier ones. You can see even the vestibule is much better in this. The vestibule is good. The bone height is good. The symmetry is good. Just that he has a small lip fall in this. That is because he doesn't have teeth in the anterior mandible. Once he's rehabilitated, I'm sure it will look much better. Another case where the mandible along with the condyle was resected. So in this, we thought that we should go ahead with a custom plate with the condylar head and treat it as a extended TJR. So these were the CT scans that was sent to STARS Chennai, and then these were the images after segmenting the CT that we had received, and we told that we are going to disarticulate the condyle, and this is going to be the resection margin. We got a plate designed from there, and the fibula was positioned as per the actual or a better position. You can see that the fibula is lying a bit more higher, and then your fossa component is positioned in a good position, taking care of your pneumatization of your zygomatic arch. So as per plan, we went ahead, resected, placed the implant and the fibula. You can see that our facial symmetry is good, our mouth opening is good. There's no deviation on mouth opening. In this coronal section, you can actually appreciate the position of the bone, which is not contacting the lower border of your plate. It's much more higher, so that takes care of your bone height as well. And at the same time, you have your joint also, which is replaced here. So one addition that we had told in this particular prosthesis was we wanted a hole at the head of the condyle so that we could suspend it to the zygomatic arch a bit passively, so that there's no condylar sag, because once you strip off your pterygomesenteric sling, there's a high chance that your condyle may sag. So to counter that, what we did was made a small hole in the implant, which was designed over there in Chennai. There was a small hole, and then a PDA suture was passed through that, and it was fixed onto the zygomatic arch to prevent condylar sag. The last case that I would be discussing a case of ameloblastoma. She was from Maldives. She flew down for the procedure here. Extensive lesion starting from the right condyle up till the left angle of the mandible. This was her CT. So a bigger prosthesis with the joint. This was the hole that I was talking about. So onto this you can hitch a suture onto the zygomatic arch so that it is suspended till the fibrosis actually happens below. This was the cutting guide that we used, and the fibula also had a cutting guide. We had placed it onto the plate and then fixed it onto the mandible. That's her after the procedure. So what we usually do is, if the mandible is dentate, we keep the patient on intermaxillary fixation for a while, at least on elastic, so that the joint is trained and they know how to open and close the mouth. So that is kind of a physiotherapy that they usually undergo at the end of the procedure. But for her, that's not possible because she doesn't have teeth. So we had to be more careful that she doesn't have a mandible that is hanging. So she was. That's when we considered passing the suture through the condyle and holding it there. So the take-home message would be, whenever possible, you should use intraoperative surgical stents or guides so that your procedure is more accurate and predictable, so that you don't have any confusion during the procedure. And I would suggest that you should use, as far as possible, you should use custom plates, because one, it gives you a better outcome in terms of aesthetics and function. At the same time, your plate positioning is also much better. Thank you.
Thank you very much, Arjun, for the wonderful presentation and very complex variety of cases that you've shown. Amrita is one of the very few institutes which has a very, very solid team. I mean, they work as a team, both surgically extremely skilled and as well as technologically extremely equipped also. And I'm glad to be associated with Amrita, and it's a learning curve. I mean, Arjun knows the kind of interactions that goes on in WhatsApp between every millimeter is checked over there. I mean, that's the way you learn, honestly. So like I said, it's not that we as a company do a great job. It's just that we have great mentors, great teachers who teach us and who equip to us and who train us. And Arjun has been a good support and a very big support to us. So thank you, Arjun.
Sir. I would like to add, all this is not possible by just sitting and discussing the reflection margins. We need to have a good team who understands and tries to replicate our ideas. So your team and your company has been very much helpful to us. Thank you so much. We look forward to working with you again.
Yeah, thank you, Arjun. Thank you so much. The last speaker for the day is going to be Dr. Leroy Clark from Canada. Dr. Leroy is a co-founding director and the vice president of Center for Rehabilitation and Health Services. He's responsible for education, development, and training. STARS is in partnership with Crash Canada. It is developing a cutting-edge emerging global provider in digital solutions for healthcare. In addition to his responsibilities for professional training at Crash Incorporated, Dr. Clark has a passion for suitable STEM professionals pipeline through mentoring and coaching. He's actively involved in that sector both nationally and internationally, and he has great academic and practical experience in clinical laboratory medicine, education, and neuroscience research. He obtained his PhD in science and technology education with a focus on mentoring from the University of Toronto. And he's convinced that investing in our youth is investing in the future of our local and global communities. It's always been a great interaction with Dr. Leroy over the last few months. I see the passion that he has when he's talking about training and technology and design. So I would want the stage to open the stage to Dr. Leroy to share your experiences and to teach us and to tell us what you want to say. Over to Dr. Leroy.
Okay. Are you able to see my screen?
Not yet, Dr. Leroy. Yes, you can see it. Yeah, we can see that, yes.
Okay. Thank you so much. It is indeed a pleasure to sit and be a part of this amazing August group. And no disrespect to the younger members at all. Not August in the sense that you are indeed very well on top of your game. All that we are doing is certainly exciting, and my own background in neurosciences and stereotactic surgery back in the 80s has been a great asset. But any knowledge that we have, if we do not disseminate that knowledge, it is as good as sitting there waiting and no one will use it. Not to say that this will be the case, but we have to be proactive in presenting this knowledge and also training the next generation of scientists, surgeons, and so on. And so I see this as an amazing opportunity to pass this on. So thank you again, Dr. John, for your role in our work here with this group, as well as 3D GRAPHY for making this possible. I'm certainly very excited about the future and what it will bring for us. So my topic today is about advancements in digital healthcare technologies and opportunities in education, training, and development. Now, I want you to know that this is very preliminary work that we are doing here at CRES in conjunction with STARS, but it is exciting work. The summary, and I will not go through all of this, it will be available for people to read if they so desire. And it just tells us a little about what this is and the opportunity to be involved in either synchronous or asynchronous technical training and development. Our center is partnering with the Center for Technology Assisted and Reconstruction Surgery, STARS. It offers a menu of training and development courses for both initial acquisition as well as fine-tuning of cutting-edge skills in digital healthcare sector. And our courses will range from introductory to more high-level professional training, such as what you've been seeing today. A brief background and context. Our history goes back, first starting with our director, Professor, our CEO and President, Professor Onwobolo, who you presented this morning. And back in 2017, he leveraged his own technologies as owner of a 3D company, along with one of my colleagues, Dr. Olufemi Adigon, and who had interest in commercialization of small business ideas. Both individuals saw the possibilities which digital technologies offer to the healthcare sector and move forward. Back in January of 2019, myself joined as Vice President of Education, Training, and Strategies. My background in science and technology education, as well as clinical laboratory science and neuroscience research, was useful, and we incorporated that in the launch of our center on late October 15, 2019. So we are still crawling. This is our director. Here is Dr. Onwubolo, Dr. Femi, and myself in our laboratory. Our marketing and sales, we have a marketing and sales team, and here they are as well. Continue our background and context. The Center for Rehabilitation and Health Services, Inc. is an emerging provider of digital solutions in dentistry and other technological products and services in healthcare. Our state-of-the-art facility is located within the culturally diverse cosmopolitan city of Brampton in Greater Toronto Area, Canada. Our highly qualified and diverse team includes administrators, technical and medical advisors, registered dental technologists, RDT, and technicians, as well as our multidisciplinary team of directors, Doctors Onwubulo, Adigan, and myself. With our high-tech scanners, automated milling process, and 3D additive manufacturing technology, we offer timely and high-quality service to our clinicians and referring labs, while participating in collaborative academic and industrial research in the areas of digital dentistry, orthodontics, and prosthetics. Now, our products include digital dentistry, orthodontics, models, digital archiving model opportunities, wax-ups for crowns, models for replicating dentures, surgical guides, indirect bonding trays, bite splints, and so on. Products and prosthetics, continued customized sockets for lower and upper missing limbs, complete artificial limbs, orthotic devices for seniors. Solutions in missing limb category will benefit war veterans and other differently abled people, while orthotic devices are more beneficial to seniors. Now, Chris is not thinking just locally, as you can see in terms of our collaboration with STARS. We have an EXPO, the overseas division, and we are looking at different parts of the world. Education and training. We clearly, this is a very important area for us. And quite frankly, this is quite different from other organizations such as ours, because this is not generally one of the arms of these groups. But education and training and professional development is a critical part of what we do. So we are looking at digital dentistry currently, digital medicine, which will include veterinary medicine in the future, digital orthotics and prosthetics, still pending. And our modes is webinars, online face-to-face, short courses, continuing education certificate programs. So based on some of our presentations today, I think we have a large opportunity to be involved together. Training courses. Now, this is a very preliminary study. This is introductory courses that we offer. Our training coordinator, Jessica Mazzafarro, who is a denturist, developed some of these courses, which include introduction, CAD/CAM introduction, understanding different materials used in digital dentistry, and so on. Extraoral digital scanning, scanning and designing simple restoration. So these are some of the preliminary courses, introductory courses. Intermediate courses, topics include milling versus 3D printing, and my colleague mentioned some of these already, materials recommended for each, and so on. Scanning and designing, complicated restorations, same-day procedures, and so on. We also offer advanced topics in digital dentistry, case scenarios, step-by-step for design to mill, full arch restoration workflows, same-day procedures, using intraoral scanners for designing restoration, using software for pre-surgical planning, and so on. The pilot study, we had done a pilot study, which was very preliminary, just to get a sense of the landscape and where the demographics were. We found that 60% of our responders favor 3 months training for continuing education. 40% of respondents favor 1 to 2 short courses, 2 responses. Level of training required, and 60% wanted introduction, and intermediate advanced required intermediate or advanced, and that was about 40%. 100% of our respondents agree that digital dentistry is the way for the future, and if we didn't know that today, it was clear. Now, I could invite others to share this this link, survey link, so that in case they are interested, we could expand our breadth of respondents. Now, I took this later on, make sure we put our vision, mission, and goals later on, simply because in terms of our collaboration, I think there has to be a good fit. Our vision is creating opportunities and contributing to health and well-being through digital technologies. Our mission to provide digitally enabled global solutions in healthcare by leveraging innovation, partnerships, and research locally and internationally. Our goals to promote digital technologies amongst healthcare professionals, laboratories, and other stakeholders in order to improve health and well-being. Collaboration and partnerships locally and international, as well as innovation and research excellence in all that we do. We have some challenges and opportunities. Needless to say, we have all experienced this over the past 8 months or so. Just our own story, which puts a face on it, research has shown that there's a wide range of responses to acceptance and efficacy of online adult education and training during COVID-19. There's no question, however, that there is a phenomenal rise in the utilization of online platforms such as Zoom and Microsoft Teams for professional development and training. We have seen the platform today, and I like it. And I think there's certainly an opportunity for us to utilize this. Even though a large number of professionals and in-service workers report significant benefits, such as safety, there are drawbacks, such as poor adaptation of technical skills and perceived distance and effects from clients and patients. We continue this is actually a time for us at CRES to pivot and re-strategize as to how we move forward. As you perhaps know already, there are a number of companies, startups, who just cannot and will not and did not survive. We are not prepared we are prepared to survive. So CRES launched its operation in October 2019 and was off to an amazing start. Then came COVID-19 that completely shut us down shut down our operations in March 2020. We had no choice but to critically analyze our vision, mission, goals, and value of diversity in order to pivot and re-strategize. CRES, via our president, Professor Godfrey, had developed a relationship a few years earlier with STARS via Dr. John Nissen. We thought that this was the time to take our partnership relationship to the next level, and the rest is current history. So just a partnership model here is that, I think I know my colleague Godfrey did allude to this earlier. So here's STARS, CRES Canada, and CRES, and our client, we would interact this way. So there's STARS and there's CRES. And where will we be in 5 years? We're going to leverage our partnership with CRES, with STARS. Will be one of the leading digital healthcare facilities in Canada, having high-level technology-based research and development team, as well as training activities that will shift the industry towards digitalization. We project to hold 15 to 20% of the market share of the digital healthcare industry in Canada. There are challenges, and so we have to recognize those challenges, which my colleague alluded to, such as FDA, as well as Health Canada roadblocks. I shouldn't say roadblocks, but those are what they are. They are regulatory places. Now, that is it. I'm open to questions and any feedback.
Thank you, Dr. Leroy. I think it was a wonderful overview of what is to come. So, truly, yes, CRES, this partnership with Canada is going to open a lot of doors, not just for us as a team, but also for people who want to look at collaboration, want to look at training. And then, yes, the pertinent questions that you're talking about is very vital. Regulations, certifications, and the standard methodology. In India, it's extremely critical that we do that also. Yes, we are in line. Most of the certifications done. So that's it. And thank you, Dr. Roy, for the presentation. Are there any questions that I wanted to get? Most of the questions were answered. The discussion itself. Yeah. So I'm just looking at it and okay. I guess if there are no questions, I think in the group, the team can share the mail IDs for people to start looking at meeting. And Dr. Abhay sir and Ganesh sir, Arjun, I think there'll be more and more, the more we start interacting, and also with Canada, we can do a lot of things. Thank you one and all. I think the closing ceremony is going to start in another 15 minutes. So we need to just rush over there. Thank you again. So have a nice day for Canada. Thank you, Oscar, also for the presentation. And Team India, thank you very much for your time, valuable input, lovely presentations, and have a wonderful week. I think the festival season is starting. So have a wonderful Diwali in days. Thank you so much.
Thank you, John. Thank you, everybody, for this wonderful time, wonderful lectures, great overview of 3D printing and virtual surgical planning. Thank you very much.
Thank you. Thank you. I'll exit. Thank you so much. Thank you.